We have 4 speakers for this session. I have the pleasure of introducing our current Kdsg President and Secretary of Kenya Association of Physicians, Dr. Roslyn Ngugi, who will start us off. She's a consultant physician at KIU University, very much passionate about mentorship and teaching. She's here to give us an overview of gestational diabetes mellitus and the role of different cadres in management of the same. She will be aided by our able consultant OBGY, Dr. Dorothy McKenna, who is a consultant OBGY at Lanet Regional Hospital, and her main interests are minimally invasive surgery, and she's a mentor to very many. So a round of big applause to Rosie and Dr. Dorothy.
Thank you, Esaji. Oh, great. So I thought I'd change things up a little bit and be the one to start so that I set the pace for the rest of the day. So don't stone me. Now, the reason why we had put GDM in the program was we feel there's one particular problem that we always encounter. Who's to manage this patient? Should it be Dr. McKenna throughout the pregnancy, or when things go bad, then they're like, okay, this patient needs insulin, so let's give Dr. Ngugi. So I want us to approach gestational diabetes as a clinical continuum. And the concept is behind GDM is it's not just a pregnancy complication, it actually identifies patients with a pre-existing or evolving pancreatic beta cell defect. And so the stress is the pregnancy, and which then causes severe insulin resistance, which causes profound metabolic stress, which then unmasks this beta cell dysfunction. So I want you to think about this. It has unmasked that there was a beta cell dysfunction. Does that mean that when the pregnancy is done, then the problem disappears? And that is the primary key, that a patient comes, whether they develop GDM, they are managed whether with diet or oral hypoglycemic agents or insulin. And then after they've delivered, everything is stopped and they're told, go and enjoy. Until the next time they present at McKenna's clinic saying, oh, I'm pregnant. And you see, that's a gap of, say, 1 year to 2 years to even 5 years. What's been going on to this woman? And that's why we need to think about a timeline ribbon. So the ones you'd want to check before 24 weeks, there's a certain risk checklist that you're given. Patient with a BMI above 30, has prior GDM, family history of diabetes, high risk ethnicity, or high Z score for prior birth weight, right? And then you say if you have not at any risk, then all mothers are subjected to an oral glucose tolerance test or fasting plasma glucose to be able to check at 24 to 28 weeks. Now the standard was, if your fasting plasma glucose was more than 5.1, then we subject them to an OGTT. But you know that majority of the women can have a normal fasting, but then the 1 and 2 hour postprandial, that is where the problem lies. And so at 24 to 28 weeks, the International Association for the Diabetes Pregnancy Study Group came up with this either one-step or two-step protocol. So the one step was you give 75 grams of glucose. Before you do that, do a fasting. It should be not above 5.1. Then after 1 hour, 10, after 2 hours, 8.5, right? But then we noticed it was difficult for women to come fasted. They travel long distances. They're always hungry. It's not the best thing to do. So they came up with a two-step. Why don't we come with a lady who's unfasted, give them 50 grams. If we find that the random blood sugar is more than 7.5, then tell them, come back and do now the oral glucose tolerance test. Will the majority of the Kenyan women come back? I can tell you this is also what's happening. So now what is happening is that up to 5.2% of the patients fail to complete this test because of nausea and vomiting, because that 75 grams of glucose load is actually quite nasty. So the question remains, what do we do for this particular patients who are not even willing to undergo the 75 grams of glucose. So we recently attended a meeting and we were looking at the problems that are occurring both in third world and developing countries. And they found that what if you actually screened early in the pregnancy, before 24 weeks, from as early as the time that the patient presents and says they're pregnant, and subjected them to a point of care, A1C. And we found A1C of between 5.9 to 6.4% was considered a high marker for abnormal glucose metabolism, and told them, you know what, now you should actually do an OGTT earlier and call that early GDM. If there was no risk factor, your A1C was less than 5.7, then it's not a problem, wait for 24 to 28 weeks. But then some places don't have that OGTT. Actually, most people don't even have glucometers around the country, because we actually did a survey. So I said, what if you do a fasting plasma glucose and you find at as early as 15 weeks it's 6.1 to 6.9, then we can actually call it early GDM. And so they released the current guidelines and they said you have an option, early GDM, a fasting glucose of between 5.1 to 6.9, or an A1C of 5.9 to 6.4. When they looked at point of care versus venous, there was actually no difference. And so they said you can still use point of care. So now we are advocating for testing as early as 15 weeks if it is a high-risk pregnancy. So when you look at the difference between early and late, one is, of course, at 15 weeks, the other is 24 to 28 weeks. Now, earlier you can see we are not as tight as late, 6.1 to 6.9, A1C target 5.9 to 6.4. We don't recommend an A1C later in pregnancy, obviously because of anemia. So what we are finding is the ones who actually have early GDM, they have high risk of macrosomia, preeclampsia, and early GDM. And in the next pregnancy and the subsequent pregnancies, as opposed to the risks you think about, which is more likely related to the baby, of shoulder dystocia and macrosomia. So that's something to think about. Then they've actually started looking at, when you're talking about active management, do you sit and tell your patients, if your BMI is less than 18.5, your acceptable weight gain, and that's something we'll hear from the gynecologist, should be a maximum of up to 12 to 18, as opposed to if your BMI is fasting plasma glucose or an A1C. And that is why I want you to notice this. Normal glucose at discharge does not mean the beta cell defect has resolved. So please, I'm urging the gynecologists, I can't keep saying McKenna is not the only one, but all, please send the patients back to us at 6 weeks so that we actually do the OGTT. The problem is these women will not come when they remember how nasty the test was. So what we've come up with is a recommendation because of one simple thing. We found that up to 60% of these type patients will develop type 2 diabetes, and that's a 7 to 8-fold increased risk. So what we are saying is do your A1C and fasting plasma glucose at least every 3 to 6 months if you knew that this patient especially was on insulin. About contraception, she will talk about it, but please avoid generally the progesterone related because it's associated with weight gain. So this is what we are telling you. Before discharge, tell them you're going to follow up by the endocrinologist and the gynecologist. Come and see me. If your OGTT is normal, then we can follow you up annually. If there was a defect, every 3 to 6 months. And if you find that A1C is obviously above 6.5, then they're followed up regularly by the endocrinologists. So this is some of the things that we discuss with the gynecologist about a postpartum intervention matrix. Like one, encourage breastfeeding because it's found to actually aid in weight loss. That helps with reducing insulin resistance. The option of the contraception, estrogen versus progesterone, and then of course, the exercise. So it will be minimal, just walking, but at least that is something you need to think about. And then Dr. Nicola had talked about the transgenerational cycle map. And I'm glad she talked about it because we need to understand why there's so much childhood obesity. So the mother had a GDM. Because of that, there was intrauterine hyperinsulinism. And because of that, the baby develops obesity. You don't follow that child adequately, that is a child who will end up on my doorstep, and then the vicious cycle continues. So we have to break this cycle. And how are we going to do that? Those measures, breastfeeding. If you know that the parent had gestational diabetes, then this is someone you actually want to monitor and follow up closely going forward. And so this is why we say GDM is not an isolated 9-month obstetric event. It's actually a critical diagnostic window in a patient's lifelong metabolic trajectory. So this is a patient who will continue to follow up because the risk does not diminish. And you know, with every pregnancy, it continues to go on increasing. So my takeaway is, number one, please screen the high-risk patients. Number two is the choice. So you have the option of 1-step, 2-step, or 3-step. If it's early, please subject them to either fasting plasma glucose or an A1C. Later, if they have no risks, then the OGTT. If you find you're having a problem, then do the 50 grams. But as at now, we're going to undergo some studies where we want to see the value of 50 grams versus 75. Number two, the utility of A1C even later in pregnancy. Or just using fasting glucose or random, because we are finding that we are struggling. Majority of the women who do OGTT are in the private or in level 6 hospitals. So there's a very big gap. And then postpartum is day one for the patient to come and see the endocrinologist and continue. So even those who are diet controlled, they were on oral hypoglycemic agents or insulin, please send them away. I don't need to have seen them throughout the pregnancy, but let them come and see me after so that I prepare them for the next pregnancy. Thank you very much.
Thank you very much, Madam President, for starting us off with that exhaustive outline of gestational DM. I wish to invite Dr. McKenna to give us OBGYN perspective of the same. Karibu Daktari.
All right, good morning, everyone. Yeah, my name is Dr. McKenna, conditions. So more women are now receiving screening and treatment compared to before. More women now are doing their OGTTs. We are diagnosing GDM, but yet the outcomes are still not very different. We are still getting high rates of macrosomia, and with macrosomia, we end up having high rates of cesarean section. We are having increasing rates of hypertensive disorders and future type 2 diabetes. They remain high. So the problem is not simply diagnosis and putting patients on treatment, but implementation and continuity of care. And I think that's where the team here comes in. So for us, when we look at the effects of GDM as obstetricians, there is a hypothesis that usually just informs most of the complications that we see. So when the mother has maternal hypertension that we see, so when the mother has maternal hyperglycemia, then we have that maternal hyperglycemia crossing over to the fetus, so we have fetal hyperglycemia. And if we have fetal hyperglycemia, especially in the first trimester, it can cause a lot of problems, including congenital anomalies. So we usually say if a patient preconceptionally has a HbA1c of above 10, that is teratogenic. These fetuses are at risk of congenital heart disease, they're at risk of neurotube defects. So the message to the people in this team is that even as you're managing the women of reproductive age, then they should be on effective contraception preconceptionally before they conceive, and you make sure you have achieved the ideal HbA1c levels, that is less than 6.5, so that you ensure that in the first trimester, then we are not going to have these problems. So with fetal hyperglycemia, I've said we can get congenital anomalies, we can get placental insufficiency, which will lead to fetal growth restriction, and then now we'll have fetal hyperinsulinemia. This fetal hyperinsulinemia also causes problems because it's going to cause immediately after birth. We tend to have neonatal hypoglycemia. We have what is it called? Respiratory distress syndrome, because hyperglycemia impairs surfactant production in the fetal lung. So fetuses, newborns of diabetic mothers are at risk of respiratory distress. And then the cascade continues. We have, with hyperglycemia and hyperinsulinemia, then we have fetal macrosomia. So these are the babies who will be born with weights above 4 kgs. With that comes the risk of shoulder dystocia, because fetuses of mothers with diabetes, they tend to put on their weight around the shoulder, and that causes increase of the risk of shoulder dystocia. Then we have increased risks of fetal hypoxia, because hyperinsulinemia is a hypoxic state, even in the intrauterine. So they are at risk of fetal hypoxia and neonatal jaundice. So that usually summarizes the effects of diabetes, especially in the fetus. There are also effects to the mother and effects to the birth process. So the shoulder dystocia I mentioned, the increased risk of cesarean sections. So who are we missing? So there are screening challenges. One of the major screening challenges we have is late bookings. We have a lot of women who are coming in for their first antenatal visits, maybe in the second trimester, maybe in the third trimester, and you can see we are missing an opportunity to screen, especially those who are high risk, and we wanted to screen in the first trimester. So late bookings. And then there are women who actually never attend antenatal clinics. Then we have inconsistent screening protocols. We've had fasting blood sugar, two-step, three-step. Some just do random blood sugar, which is not very useful. So we have inconsistent screening protocols. Then in our setup, especially in the public facilities, there is resource limitation. So an OGTT is not a very cheap test, especially for the common mwananchi. So we have a lot of missed opportunities, and OGTTs are not being able to be done. Mostly in the private facilities is where you'll get the standard screening. So many women remain undiagnosed until complications appear. Unfortunately, there are those who are Unfortunately, there are those who diagnose at birth. When the baby is born, it's 4.5 kilos, and then now we are looking back and we find that there was actually diabetes all along. So that shouldn't be the case. When you have early pregnancy hyperglycemia, especially in the first trimester, it's good to distinguish patients who have overt diabetes. And those who have overt diabetes are the ones, their fasting sugar is above 7, or their random blood sugar is above 11. It's good to be able to diagnose early GDM, as Dr. Ngugi has said, which you can do with a HbA1c in the first trimester. Then pre-existing diabetes, these are already known. They're already known to have diabetes, and now they're pregnant. Why women fail to achieve targets? Some of the challenges I have already mentioned, and I think cost is the biggest one. When you diagnose gestational diabetes, you're going to put these patients on a glucose chart, a sugar chart, and they're going to monitor their fasting sugars and their 1 hour or 2 hour postprandial sugars. So the availability of glucometers is a challenge, especially in the public sector. The availability of those glucose strips is a challenge. When now the sugars are not being controlled, we need to put them on insulin. It's also a cost implication. And this is some of the reasons we need to really look at. That's why we are not really achieving targets. When we diagnose diabetes in pregnancy, we need to do serial scans. And part of how to know whether we are controlling the sugars is to check the growth of the baby, where we are looking at the abdominal circumference. So 4 weekly, we will recommend scans. That also adds to the cost implication. Then they will need to be on a diabetic diet. So food insecurity, the nutritionist will see them and advise them what to eat, but then the situation on the ground is different. Maybe they are not able to afford, so there's that. Then we have cultural dietary practices. So we come from different ethnic groups. There are those who believe pregnant women must eat this kind of food, must drink mursik, must, all those things. And they can actually affect our targets in terms of sugar control. Then limited access to specialists. We've seen that we really need to have a close linkage between the obstetrician and the endocrinologist. We don't have many endocrinologists, the physicians' availability. So that also brings a challenge. We don't have enough access to the right specialties. Then we have transport barriers. We still have patients who have to travel long distances to come for their clinics, to come do their OGTT. For the OGTT, they need to come very early in the morning, before 9 a.m. That also poses challenges. And so poor glycemic control is often a systems issue and not a patient issue. And I think these are the things that we should be looking at. So when we come to gestational diabetes diagnosis, the commonly accepted protocol that is being used is the international, the IADPSG, which recommends universal screening, that all women who are pregnant should actually be screened, all women, and the screening should be done between 24 weeks and 28 weeks. So the recommendation is universal screening, and for this particular protocol, they use a 75-gram OGTT, and the cutoffs are if you have a fasting of above or equal to 5.1, then that is GDM, or 1 hour more than or equal to 10, 2 hour more than or equal to 8.5. So if any one of them is equal to or above, then that is a diagnosis of GDM. Then we have other protocols. So you might find other places where they use the Carpenter and Costan protocol. And even for them, it's universal screening. And it's what Dr. Ngugi talked about, where you start with a 75 grams glucose tolerance. If they go above the threshold, then you subject them to the 3-hour, 100-gram glucose tolerance. Then we have the WHO, which talks about selective continuum of care. So, my last slide would just be talked about future directions. We could consider digital glucose monitoring.
From awareness to screening to link up to endocrinologists. I hope during the Q&A session,
Introduce Dr. Gaman, who is going to talk to us about insights in type 1 diabetes management and diagnosis. He's going to teach us about stage 1, stage 2 diabetes, what to do when. Now, when I talked to Dr. Gaman this morning, he told me to say this is Dr. Gaman.
Thank you very much. I think what's important is what we hear, not how we introduce each other, to be honest. So I'd like to first say it gives me a pleasure to be here amongst friends, colleagues, people we've known for a long time. I'm tasked for the next 25 minutes to try and bring you up to speed with what's happening with type 1 diabetes. So I'm going to talk about what I thought was important. It may not be important to many people. There may be other important things. I may not be comprehensive. But all this is, just a talk that I was given and I was told, say what's there. So how am I going to approach this? First of all, we must understand type 1 diabetes is changing, or the care is changing from being reactive to being interventional. So we are looking at not landing up with DKAs at diagnosis. So over the next 25 minutes, I'm going to take you through diagnosis and screening, what's happening, how can we prevent type 1 diabetes or delayed, what are the newest devices now in the market the last 1 year, what are the latest CGMs now and what's in the horizon, and of course, what all patients ask you, is there a cure? What is there? And then lastly, something that's close to my heart, an innovation that won an award at the ATTD this year, Tech Award, on how can we actually test insulin to see whether it is viable with our patient next to us. So this slide is important because we didn't just end up here with all innovations. Over the last 2 decades, we've been actually having innovations in 4 fronts. Monitoring, that is CGMs, automated insulin delivery, and of course insulins have also come up, immune disease modifying drugs, and cell therapy. In the year 2000, we had something called the Edmonton Protocol, which was the first time we said, yes, we can actually have patients not using insulin. And this was exciting because this was the first protocol that had non-steroid, didn't have steroids in its immunotherapy. Around this time, we also had our first CGM, which was a CGM Gold. Over the next 10 years or so, we developed new pumps that now talk to sensors or CGMs. They communicated, they had shut down on low. But the real changes in type 1 diabetes came from the year 2022 to 2025. And 3 or 4 things happened at that time. We had teplizumab coming in, the first therapy to delay onset of type 2 diabetes. We had CGMs that now could have an MARD or a MARD of 8%. The first CGM that we used, which was in 1999, had an MARD of 30%. Then we had all these AID systems that come up, the Omnipod 5, the T-Slim, Tandem Control IQ, the islets, and of course, in 2024, now we had stem cell islet therapy. So this slide takes us to where we are now. For us, we must first understand type 1 diabetes is now formally recognized as a staged condition. It doesn't just happen. And this was talked about by a group in 2015, and they said, we need to stage. And the stages are stage 1, stage 2, stage 3. Stage 1 is when you have greater than 2 antibodies with normal glucose and you're asymptomatic. Stage 2, which is the stage of interest, is where you have autoantibodies, dysglycemia, but the patient is still asymptomatic. And stage 3 is what we all see. Patient comes in, probably in decay, insulin requiring. The importance of this is, if we have these stages and we can screen early, not only can we intervene to delay, but also we can prevent type 1 decay at diagnosis for about 80 to 90% of our patients if we are screening early. So why screen early? Previously, we would say, why should we screen when we can't prevent type 1 diabetes? But if we have the money now, and it costs millions and maybe quite a bit of millions, we can actually postpone stage 2 diabetes. And of course, if we screen first degree relatives with type 1 diabetics, we can help them to detect decay before it occurs. We can have general population pilots and look at using teplizumab to treat. We can screen patients with other autoimmune conditions so that we actually reduce presentation and hospitalization. So all this is possible. In our setup in Kenya, what does it cost to screen? Over the years, we've had about a 20-30% reduction in costs of screening or doing the antibody screen. It's now roughly around 28 to 30,000 shillings to screen. But elsewhere in the world, the cost is about 5,000 to about 8, 10,000, and in some centers, 20, 30,000. So if we really look at it, the major barrier in our setup of screening is not the science, it's the cost. So if we all, and cost comes down if we all screen more, if we have pilots, millions of shillings. In a public hospital, and we discussed it just last week when we were discussing CGMs at the ministry, the cost of a DK admission is 60 to 120,000. Now let's throw a spanner in the works. What if we brought down our screening cost to 5,000 shillings and each family could be screened for 25,000 shillings? Wouldn't that be a saving even in the public hospital? So these are some of the things that we need to think about And it's probably something we need to look at. There was a landmark when we had our first disease-modifying therapy in type 1 diabetes, teplizumab. And I know it costs millions, it costs a house per se. When someone asks me, I say, you are ready to sell your house? Then you can get this drug. But this was really a drug that slows down autoimmune beta cell destruction, and is given as a single day IV course for 14 days and delays stage 3 for about 2 years, because a placebo, it delayed about 2 years. So you can say roughly 2 years. But the change occurred this year when the FDA expanded its approval for use in patients above 1 year. Before, it was at 8 years, the previous studies. And this came about from the Petit study that I'm quoting down there. So why is it critical? Because below the age of 8, progression is fast to requiring insulin. And hence, the importance of this particular group, screening them early and treating them. And this is now available in the countries listed there, but it's still quite way beyond. So how would you use it? Who would use it for, when, and how? It's eligible to be used at stage 2 with 2 antibodies and dysglycemia. And here you may have issues with cytokine release, rash, and things like that. And is now approved for above the age of 1 in the US and above the age of 8 other countries. And it's a single IV dose for 14 days. So having gone through that, now let's look at what are the devices that are new in 2025, 2026. I would pick 2 devices. There's the Minimed Flex pumps, which are now about the size of 2 vials of insulin, or about 2 centimeters or 3 centimeters by 10 centimeters. But what's important now, we have technology that has meal detection. For those of you who know the problem with type 1 diabetes, it's really bolusing before meals. And even those who use pumps and AID systems, they have a problem in the sense they don't announce their meals. And if you have a system that is able to pick that the meal is occurring, either from the rise in the sugar, the timing, and these are all AI driven, it becomes useful. So what are the 2 new competitors in this particular market? The Omnipod is the top range pump at the moment in the world. It's actually tubeless. And the Omnipod, the next generation, which is just about to come about, is a fully closed loop. Fully closed loop means you don't announce anything. You don't say, I'm eating. There's data in type 2 diabetics, and they are looking at studying also type 1 diabetics. So for me, this is an interesting take, because I feel that these 2 pumps will actually change the landscape in terms of improving care for patients who actually don't want to announce their meals. They don't want to tell the pump they're eating, or they forget, and they are going through a tough period with their adolescents and everything. They want to have a pump on and it does everything. So I think these 2 will be leading the field. What about CGMs? What's available now is we've moved to 15-day CGMs. We've moved to companies not producing CGMs for themselves, like now Abbott are producing CGMs for Minimed. We also now have a 21-day CGM coming up called Instara. But what's on the horizon, and probably towards the end of this year, is the Libre Duo, which is a dual ketone glucose monitor. We know that when your ketones hit about 0.8, your risk of decay is very high. So this monitor will monitor both glucose and ketones. Then we have a GlucoTrack, which is a implantable sensor in the superior, in the vena cava. It lasts for about 3 years. We have others, the GlucoWare watches, which use radio frequency, but the data is very weak on this. And then we have, of course, AI-powered CGMs that use voice recognition to understand meals, So this is some of the things that are there in the continuous glucose monitoring field. What about cell cures and cell therapies? And I've picked 4 areas that are of interest and I think will be of interest for us. So we have the Vertex group that have zimsilacel, which is a stem cell islet cell therapy, but they do use immunosuppression here. Tegorupat. This is important in the sense that we have now data that after 1 year, about 10 out of 12 were independent of insulin. They had an A1C of less than 7% and were above 70% time in range on CGM, 1 year down the line. For me, my favorite is the Sana biotechnology. This is a hypoimmune engineered transplant without immunosuppression. So here, no immunosuppression. And the data here at 6 months and 14 months is that they still have beta cell production. Then we have Serenova, which is an islet cell pouch, a pouch that is put in the body, in the abdomen, about 60 millimeters by 60 millimeters. That pouch allows the vascularization to occur and the beta cells are put in there. But here you need immunosuppression. What's interesting is now we have a new immunosuppressant, Tegrupat. I have a problem pronouncing it, but what you must know, it's unlike the other immunosuppressants, which it specifically targets the T cell and doesn't have the challenges we had with the other immunosuppression. So I think putting this together, when you have a patient in front of you and they ask you, doctor, am I going to really have a cure? You can tell them this with certainty. Yes, there are actually now several people off insulin, but this is still investigational because this data is about 3 years old. The islet cell pouch is 3.5 years old. The others are about 1.5 years old. But you can see we now have data built up for up to 3 years. So the 3 main hurdles we have is immunosuppression, because we need to use immunosuppression. If we get away with that, it will be better. Scalability. And now we know we don't have enough donor cells, so maybe stem cell cells would be useful. And of course, durability. Will these interventions go further than what we have seen? AI in diabetes is growing, and this is really 2 areas that I'd like to bring about. This is from the University of Virginia. You won't believe it, the person leading this program is actually a mathematician. Boris Kovacek, just look him up. And he's come up with these fantastic ideas just from modeling. So he has this EDANET, which is really an AI-driven closed-loop system. That just therefore now, there are courses coming up, and this is 2 groups coming up, the ATTD and Breakthrough Type 1 Diabetes. Breakthrough Type 1 Diabetes, for you who know the old nomenclature, is the JDRF, Juvenile Diabetes Research Foundation. They now have grouped together to probably come up with these interventional courses that will help you deal with this new generation. So all said and done, I mean, we really need to look at type 1 diabetes as not only treating DK, but how can we look at it earlier? How can we look at therapies that can change? And I believe in leapfrogging. I don't believe that let's first get all our patients to have insulin first and then machines first. We must also leapfrog and see what technologies are there. What can we, and have reasonably good data on it. We've talked about CGMs that are smarter, more accurate, lasting longer. We've talked about monitors with ketones as well coming to help you detect ketoacidosis. We've talked about non-invasive glucose monitoring. We've talked about cell cures getting closer, and we've talked to you about what you can tell your patient on how far we are. And of course, we've discussed an innovation that will help you determine when you're sitting with a patient whether their insulin is potent or not potent. Thank you.
Clap for yourselves for being early. Thank you, Dr. Gaman, for that insightful talk. Are you incited to go where? Singapore or precision in managing type 1 diabetes? Precision. So we've learned that we can delay DKA by screening and using appropriate medications. We are moving towards a place whereby we can monitor glucose non-invasively. We can use pumps that can deliver insulin for more than 30 days without interferences. So maintenance is minimal. So you are all incited to precision in managing type 1 diabetes. Now I have the privilege of introducing another key speaker who is going to teach us about, to speak further about the digital twin that Dr. Gaman has talked about and other insights in molecular biology. The subtle biomarkers in endocrinology that could assist you to know that this patient is likely to develop PMOS, previously known as PCOS, or to have, in a family whereby you have autoimmune diseases, you can pick the ones who will develop type 1 diabetes and all. And this is none other than Dr. Rabia, the director of the Dr. Kalebi Labs. Welcome, Dr.
Good morning, everyone. The disadvantage of me going after such wonderful presentations is that mine will just be, baseline compared to the rest of them. So thank you for having me here. My talk today is called Precision Diagnostics in Endocrinology. Basically, I'll know my job is done when I manage to convince all of you that genetics has become something that you can use in your clinics. And it's not just something that you've read about in papers from London or Boston, around the world. My name is Dr. Rabia. I'm the Technical Director, Chief Technical Officer at DKL, and I'm a molecular scientist. So just very briefly, DKL was established in October 2024. We're not far from Kenyatta. It's the first private lab in Kenya to be registered as a Class G, national and international. And we have advanced platforms with total lab automation, molecular diagnostics, digital pathology, flow cytometry, but also now we've introduced next generation sequencing, which is what my talk is about. We're ISO accredited and on CAP proficiency testing programs. So the shift in precision medicine, conventionally, we've all seen that one size fits all. There's late stage complications, misclassification of diabetes type, and suboptimal therapy for phenotype. But the precision approach is that you have biomarker guided treatment, early subclinical disease detection, the genomic subtype classification, and personalized therapeutic targets. So let me start by why this matters now, because 10 years ago, this would have been a much shorter presentation and less useful to all of you. So 3 things have changed over time. The cost has gone down. So targeted gene panels and single gene costs are now much less than what they used to be a decade ago. The turnaround time is faster. We're talking about 2 to 4 weeks for most panels now, which is fast enough to actually guide the treatment for a sick neonate or a family who's waiting on the screening decision. And thirdly, which I want to really emphasize, is that the genetics test is not only for the patient that's in front of you, it's for the sibling, looking at biochemistry, imaging, the clinical picture in front of you. The clinical picture in front of you. The genetic testing earns a place only when the DNA result is going to do one of three things. One, it will change the treatment. A specific gene will tell you the drugs to use, if it's a different drug, a different dose, or whether you're actually going to give treatment or not. Secondly, it changes surveillance. So a mutation will tell you to start screening the patient and their at-risk relatives for something that hasn't happened yet. And thirdly, it changes the family risk. So a confirmed variant tells you to test asymptomatic relatives. And just as importantly, it lets you release the ones that are negative. So there's no unnecessary monitoring and a lifetime of tests and stress. Let me open with this case of a 19-year-old diagnosed with type 1 diabetes at the age of 4, on insulin ever since. Her mother and her grandmother were also diagnosed with diabetes in their 20s, both lean and both on insulin. Her Gd65 and IA2 antibodies were negative, and the C-peptide reserved. And 15 years after diagnosis, the C-peptide was still preserved. There was no decay at presentation, no acute illness that triggered it. So what do you do with this patient? If your instinct is to say she's stable, controlled, and just to continue with the insulin, note that 3 generations of the lean antibody-negative diabetes that all started young, that is not a coincidence. So you'll need to look deeper. I'll come back to this case. Let me just talk about, after I've talked about MODY. Monogenic diabetes is common enough to miss, but it's very easy enough to find. Monogenic diabetes makes up an estimated 1 to 3% of diabetes. It sounds small until you realize that over 80% of MODY cases worldwide are initially misdiagnosed as type 1 or type 2. The data here is still limited, but the clinical pattern doesn't change. So the screening logic applies here as well as anywhere else. There are more than 13 known genes for MODY, and the 3 of them cover almost everything you'll actually see and act on clinically. You don't need any genetics referral pathways for this, but you just need to ask yourself these 4 questions. Were they diagnosed before the age of 25? Did they go years without needing insulin? Were their antibodies negative? And is there a parent or a grandparent with the same pattern? If you're answering yes to any of these, think MODY before you think anything else, and think of genetics. So the 3 genes that cover most clinically actionable MODYs CGK for MODY2, HNF1A for MODY3, and HNF4A for MODY1. So what changes when you know the gene, the genetics of the case? So for MODY2, the MODY type 3, but then in that case, you'll screen relatives for the same. For neonatal diabetes, it's diagnosed before 6 months of age, is monogenic until proven otherwise. So roughly half of these cases carry mutations, the KCNJ11 or ABCC8, and these encode the pancreatic KATP channel. So without genetic testing, there's lifelong insulin injections or a pump in a setting where supply, refrigeration, and costs are barriers for families. And with that result, over 90% of these infants can transition off insulin. Here's a simple algorithm for monogenic diabetes. So if you suspect it, diagnosis of below 25 years, antibody negative, multi-generation history, or diabetes under 6 months of age, then you'll screen. So the first screening would be antibodies, a C-peptide, and you'll get the history, proper history. You can then send for targeted genetic panels or a single gene test, and then you act. You adjust the treatment, screen the relatives. One thing you need to note is that pre-testing counseling matters. So you tell the patients before the actual result comes. So you counsel them before. We're going back to the 19-year-old. So what happened? The panel comes back positive for HNF1 variant, and it was confirmed in her mother and her grandmother. So 3 generations, 1 cause, and 1 actionable result. The insulin can be stopped and start on low-dose sulfonylurea. Her HbA1c actually improved within 3 months, and her 2 younger siblings have now had the predictive testing before they developed the symptoms. So this is going back to the 3 boxes from earlier, where you put out one family and it changed the treatment, it changed surveillance for the siblings, and it changed the story for the whole family. Just very briefly going to the endocrine tumor syndromes. M1 classically presents with parathyroid, pituitary, or pancreatic or duodenal endocrine tumors. You suspect it when you see primary hyperparathyroidism before the age of 30, or multiple gland disease. Testing confirms the syndrome and starts a lifelong biochemical screening program before the next tumor becomes symptomatic. MN2, which is driven by the RET gene, and the classic triad of medullary thyroid cancer, pheochromocytomas, and in MEN2 parathyroid disease. Here is what I want you to take home, is that any medullary thyroid cancer at any age, with or without family history, should trigger RET testing. So about a quarter of these cases are hereditary, even when nobody in the family was ever known to have it before. And specific RET codon that you actually find predicts how aggressive the cancer will be. and it will tell you the right age for preventative thyroidectomy. So with one ret result, you've protected 3 generations. So in this case, a 37-year-old presents with medullary thyroid cancer. Red testing confirms the pathogenic variant at codon 634, which is a high-risk category. And it's a more aggressive disease. So for the index patient, that means you do a thyroidectomy, which is now followed by annual screening. But then for her two siblings who test positive, they have thyroidectomies in childhood before any cancer develops. And then you can do testing for carrier testing, so any predictive testing for children. Just very briefly, most thyroid cancers are sporadic, but a cluster of differentiated non-medullary thyroid cancers in a family or thyroid cancer alongside any other specific findings should actually prompt a broader genetic look. With other endocrine conditions, CAH, the genetic confirms the diagnosis and then again guides the family. So here, universal newborn screening is not yet routine. So many cases still present clinically with ambiguous genitalia or salt wasting crisis in the first weeks of life. And here are some other endocrine conditions where genetics will change the management. SDHX genes, AIP, KSR genes. So now, like I said, NGS is in DKL, we've introduced it. So why does this matter? So for many years, endocrine genetic testing was confined to overseas referral labs. You could only do genetic testing if you were referring out of the country, not here. Long turnaround times, high costs, and limited, not everyone could access it. Today is more improved, it's expanding locally. So we have local labs which are doing genetic testing, they have the capacity, and it can then be clinically actionable. So what has changed? It's faster, more affordable. So looking forward, the question is no longer can genetic testing be performed? The question that you should be asking is which patient will benefit the most from genetic testing? So genetic testing is rapidly moving from a specialist academic service to practical clinical tool. But then not everybody will understand what a genetic test, when the results come back, what it actually means. You'll most likely see one of these 4 options is either pathogenic variant, a likely pathogenic variant, a variant of uncertain significance, or a negative result. So pathogenic variant will mean the variant will cause disease, and it will directly influence the diagnosis, the treatment, surveillance, and family screening. Likely pathogenic would mean very high probability of the disease association, and it's usually managed similar to the pathogenic variant. With variants of uncertain significance, VUSs, there's insufficient evidence to determine whether the variants actually would cause the disease, but clinical decisions should not just be made based on these. And the negative result does not exclude genetic disorders. The causative variant may not be known or may not be detectable, by the test, the assay that has been performed. And when you're seeing a patient, this is what you should consider when you're referring for genetic testing. Was the diabetes diagnosed before 6 months? Young onset diabetes, was the patient did it have a preserved C-peptide? Was there any history, family history? Was there any strong family history of diabetes? When you're looking at the carcinomas, so are there any disorders of sex development or endocrine disease with striking family history? So, like I said previously, endocrine diagnosis previously relied on clinical assessment, biochemistry, and imaging. But today, endocrinology is entering a new era which incorporates the phenotype, biochemistry, genetics, genomics, digital health data, and AI. And you need to keep in mind that a single genetic diagnosis will change treatment, it will change prognosis, change surveillance, and change family risk. It will change the lives of the whole family. The most important question to ask is the genetic test is not the one that we perform, but it's one that we recognize should be ordered. So from myself and the whole DKL team, I'd like to thank you.
Thank you, Dr. Radia, for that insightful talk. At least we are now aware that the tests are becoming cheaper and the timing for getting results is shorter. So we can request for this test and stop managing young diabetes patients like they are type 1 when they are not. At this juncture, I would like to invite Dr. Kdsg to invite our next speaker. Thank you.
Thank you very much, Florence. I believe the past 10 years have been an exciting few years in the world of diabetes. At each turn, at each bend, we get a novel molecule that has revolutionized how we look and manage diabetes. From the times of SGLT2 inhibitors to now the new generation's GLP-1 receptor agonists. These molecules have come to shape our practice, to change the narrative in cardiorenal metabolic outcomes of our patients. Today we have the pleasure of listening to how one such molecule, this time the metabolic angle of diabetes, how this molecule has come to revolutionize how we treat our type 1 diabetics and type 2 on basal bolus or otherwise any other regimen. This molecule is degludec. I'm saddened that it hasn't received much noise, and who better than Ombui to make that necessary noise for this molecule this morning. Dr. Davis Ombui, please take the stage. Dr. Ombui is a consultant physician endocrinologist at the Aga Khan University Hospital. A round of applause for the speaker, please.
My work is just going to be very simple. It's going to explain the science of why this insulin is the best basal insulin that we have currently in the market. And I'm going to do that by showing you the science. But before we start, maybe we can just engage in a few questions. So, by show of hands, watching The Polygamist on Netflix or the Football World penalty shootout can interfere with insulin action in a patient on insulin. True or false? True? Raise your hands. Next question. An insulin pump is loaded with both rapid and long-acting insulin to deliver impulses to patients with type 1 diabetes. True? Any true? The third question, patients can develop DKA with normal glucose readings. Any false? Don't be ashamed, it's okay, we are learning. Okay. And the second last question, glucose uptake by the brain is insulin independent. True or false? Now, the last one. Some patients on management for type 2 diabetes will require insulin as their pancreatic beta cell function declines. So all these questions are meant to guide our talk to know why do we really need basal insulin, what is unique about patients with type 1 and type 2 diabetes, and where does this molecule fit in? So my name is Ombui Davis. I'm an endocrinologist, as you've been told. We are going to start in a very simple way. What is basal insulin? I mean, we can't be talking about insulin here, and yet we don't know the terms. But how I'm going to present it is different. I'm going to show you a graph, and in this graph, I'm going to show you what happens when a person who does not have diabetes takes food. So if you look at that, when the yellow line is for insulin, the blue line is for glucose. So anytime you eat, the glucose goes up, and the insulin, which is being produced by the pancreas, just follows it along the way throughout the day. So, as you can see, from the normal human body, there's nothing really like a basal insulin or a bolus insulin. It's just that insulin that is being secreted by the pancreas behaving differently for different situations. And we tend to maintain that sugar range at a very narrow range of just between 3.5 and around 7. But then, that is not the same for patients with type 1 diabetes. If you look at that, oh, what have I done? It's not me. Okay. So if you look at that, for a patient who has type 1 diabetes, if you see the yellow line, that is trying to tell you they are nearly deficient or deficient of insulin. And their glucose will behave like that. It will be just above the normal range, and there'll be nothing really to control that glucose. Okay? So they'll tend to have this persistent hyperglycemia throughout the day. Now, if you look at type 2 diabetes, yes, they have some insulin, okay? They may be facing some deficiency in the production of insulin or some resistance in terms of insulin action. Yes, they have the insulin, but the glucose tends to fluctuate on the higher side of what is expected of that range. And what is the reason for that? The reason for that is this. For a patient who has type 2 diabetes, for example, there is background production of glucose in their fasting state that is not controlled by insulin. So because insulin puts a brake on the hepatic glucose production, basal gap, okay? So at the end of the day, that basal gap is where you are going to fit in where you need your insulin. Because at some point when you're going to measure their glucose will always start to range from a higher figure than a normal person. Now, the ultimate objective then of the basal insulin is to control the glucose, because when you're not eating, your liver is actually producing glucose for you. But the outcome then is if you suppress that glucose production, then you should be able to lower your fasting blood glucose. Now, we've come a long way in creating basal insulins. But the question is, why have we not reached that peak, scientific level of creating the perfect basal insulin? And these are the challenges we face. One of the challenges, as I'll show you in a different graph, is that these basal insulins tend to peak. And when it tends to peak, it tends to cause hypoglycemia. So you're looking for more of a flatter profile of a basal insulin so that you don't get those peaks. Number two is the day-to-day variability. I mean, you tend to exercise, you eat, you get ill, there's problems with absorption. So even if you give the correct amount of basal insulin, these other external factors tend to affect how that basal insulin works. Number three is looking for this insulin that will give you a true 24-hour cover. Because you're also trying to reduce the number of injections that you're giving to your patient. And if you can actually get an insulin that can give you that 24-hour cover without fluctuations, without peaks, then you've actually gotten to the best of insulin that you can get. The other challenge is the timing. I mean, for most of you prescribers here, you've understood that some of these basal insulins you're told to give at specific times. But we know the nature of human beings. It's not all days where you'll be there at the right time, at the same place, with the insulin that you need to be always be giving that insulin at that specific time. So if you can have an insulin that you can give at maybe varied times, it can allow you to give, for example, today you can give at 7, tomorrow you can give at 9, and it doesn't affect the functionality, then that's really a good insulin. And other challenges that we get is nocturnal hypoglycemia. I mean, we know patients, some of our patients actually have the challenge of failing, to up-titrate that dose because they fear nocturnal hypoglycemia. And nocturnal hypoglycemia is scary if your patients have actually ever explained that to you. And that is what I was talking about, the titration ceiling. Because when they fear titrating up, then you tend to have a suboptimal glucose control. One of the things that we need to understand when it comes to insulin is how do we modify this insulin to work for a longer period of time? Because you have a bolus insulin that you can give and it works immediately on that meal that you're giving, but you also need this insulin to last for a longer duration of time, especially to handle the glucose that is coming out of the liver. And what you do to that insulin is called protraction of insulin. So insulin protraction is whereby you're trying to increase the longevity of that insulin when you give it to the body. And there are various methods, as you can see, over time. We have NPH insulin, we have glargine, we have Detamir, we have Degulec. And you can see, for example, glargine, what they do is it comes in a sort of an acidic pH. Is it acidic or alkaline? So a pH of 4. And when you inject, it forms microprecipitate in the body and releases slowly. So that is how you protract the action of that insulin. For Detamir, it gets into the body and it binds onto your albumin, and it's also released slowly to protract its action. And now we have Degludec, and I'm going to show you how it works. So the small components of it, which are called monomers, are binded into dimers and hexamers. So you form complexes, which when you inject, they break down slowly and over time release that small amount of insulin into the body, and that protracts its action. And this is just a graph to show you for how long we've come. I mean, if we start, you can see that the first kind of long-acting that we had was NPH insulin. And the problem with NPH insulin was getting this peak and it not giving you that lasting 24-hour duration that you have. So it was not the best, but that is what we had. Later on, we got Detamir. And as you can see, Detamir is still giving you that peak. And it doesn't last as long as 24 hours. And in that, you tend to give it twice a day. Now, then came insulin glargine, which is what we've had for a long time in our market. Yes, it gives you a relatively flatter profile, but it's also not a true acting, long-acting insulin. And you'll find some physicians actually giving this insulin twice a day. Then, the insulin of the moment, Degludec. As you can see, it rises and gives you much of a flatter profile for the day. So it tends now to achieve that thing that you are looking for. An insulin that can give you a steady state for more than 24 hours, an insulin that is not associated with peaks, meaning that it will actually put you at risk of hypoglycemia. Now, if you look at the molecular mechanism of the two best long-acting insulins that we have in the market, as I had said, if you see for glargine, what it does is it gets into the tissue. It gets into the tissue because of the change in pH. It forms precipitates and breaks down. But the problem is that, you see, this breakdown can be affected by a lot of things, which include temperature and absorption site. So it's not one of the best that we have in the market. But if you look at this is Degludec. It tends to form all those hexamers. So, and the breakdown now is at a slower rate, which breaks down in an even manner to give you a steady state of insulin for the 24 hours that you need. So, we've looked at how the human body behaves. We've looked at how type 1 and type 2 diabetes behaves. We've looked at the history of the long-acting insulins and what factors you'll be taking into consideration when you're looking for a long-acting insulin. And now, we have to ask ourselves, then why does Degludec tick all these boxes? And that is now where the science comes in. Now, when it comes to science, and I'm sure most of you here are scientists, we're actually now going to look at the studies which have made Degludec to be the type of insulin that you're looking for if you want to push your patient on long-acting insulin. Now, much of these trials that I'm going to speak about, they are actually non-inferiority trials. And the reason why they are non-inferiority is because you are trying to compare this insulin to what is standard in the market to make sure that it does not increase any harm, number one, and number two, it's as good as what is in the market, and if possible, it reduces some risks that are associated with what was in the market, okay? So one of the trials that we are going to look is the BEGIN trial. Now, the BEGIN trial was actually designed as an inferiority trial. As you can see, the population was type 1 and type 2 patients, and the intervention arm was the Degludec. The comparator was what is standard in the market with insulin glargine. And what they were trying to see was, in terms of HbA1c reduction, is it as good? But to me, that's more vanity. What to me was more important is take patients with type 1 diabetes and patients with type 2 diabetes who are at a high risk of hypoglycemia, okay? And they start them on two arms, okay, which are crossover. Patient is put on insulin glargine and they are switched over to Degludec, or they are started on the other way around and switched to glargine. So the patient acts as their own control, sort of, okay? And now you tend to see which of these insulin is associated with lower incidences of hypoglycemia. And as you can see, Degludec was actually associated in the incidences of hypoglycemia. Now, this is one of those interesting things that I think we'll be talking for some time. Use of insulin, are they safe? And they compared this to, And they compared this to detamir, and what they found, was that it didn't increase maternal risk or fetal risk. It was just as good as detamir. And this has led to actually the Canadian Association, to the Canadian medical agency to allow this drug to be used in pregnancy. We are still waiting for FDA and European Medical Agency to approve this. So maybe with more studies, you may have to come and use this molecule in pregnancy. Now, we've learned about all that, and the next thing we ask ourselves then is, how do we use this medication? It's just as simple as how you've been using insulin glargine. The dosing for naive patients who are type 2 diabetes is 10 units. For type 1 diabetes, it's how you've always been using, how you've been calculating the dose for patients who are type 1 diabetes. If you are switching a patient from glargine to degludec, the ratio is just 1:1. There's no difference. Now, the other thing that I wanted to highlight is, I know it works for more than 40 hours. Then the question is, why do you give it then every 24 hours? Now, these are the mechanisms. That is the insulin you inject. That is what is in the depot where you've injected, and that is what is in the circulation. What breaks into the circulation is usually around 50%. So on day 1, you inject 10. What is in the depot is 10. What gets into the circulation is 5 units. On day 2, you inject 10. Now the remaining 5 units that you had yesterday, you add 15, you get half of that goes into the circulation, you get 7.5. On day 3, you inject 10, what you had as a balance was 7.5, you add to 17.5, the 9 goes to the other side, and from there on, you tend now to achieve the steady state as you go on. So it will take around 3 days to get the titration right, and after that, you get a steady state. Now, that gives you flexibility because you can now use this drug between 8 and 40 hours, okay? So it's not one of those medicines where I'll require you to know that you have to inject at the same time every day. You have the flexibility, and because of human nature and because of the significant things that might be happening to our patients, they have a bigger window on how to use this medication without worrying and getting that anxiety on when they're going to use their insulin. The risks are there, but they are not as much. The weight gain is there, but it's not as much. It can go to up to around 2 to 3 kilograms. You can get lipodystrophy just like any other insulin use. And the other thing I wanted to highlight was, when now do you use this? Who is the appropriate patient to use it? Type 1 patients, they need it. Type 2 patients, they need it. But what is the indication? Remember, you cannot use this drug as an IV. You can only use it as subcutaneous. It's not allowed in infusion pumps. So those are the things that you need to know. The reason why we use insulin in type 2 diabetes, the Monia graph, I'm sure most of you have come across it, is because as the, how do I go back? As the HbA1c goes up, the contributor to that HbA1c, bigger contribution comes from the fasting blood glucose. And you know that the fasting glucose is better controlled by a basal insulin as opposed to a bolus insulin. So that's the reason we are giving it. And I know the guidance has sort of changed. If you look at the 2026 guidelines, they say for an injectable therapy, the first thing now that they recommend to use is a GLP-1, but there are in situations, especially when insulin is needed, when the patient has catabolic issues, so they are losing weight loss, you know, they are symptomatic of hyperglycemia, you are mandated to use insulin in those states. So as I wind up this discussion, the question is, I'm attaching the evidence to what I think is going to be the take-home message for you. One, if you see, does this molecule reduce the risk of hypoglycemia? Yes, it's better than what is in the market, and that is in the switch 1 and switch 2 trial. Sorry, I just keep flipping the wrong button. I don't know. Oh, I'm done. Oh, I stopped clicking. There you are. I'm just trigger happy. Anyway, then number 2, if you look at the flexing options that it has for you, these are drugs that you can easily use because it gives you a flexible period on when you can use this medication. Is it safe in CKD? Yes, it's safe in CKD. The CKD subgroup that was used in the DEVOTE trial, it actually showed that it was a safe molecule. Number 4, is it safe in pregnancy? Yes, I've shown that. Is it safe in elderly? Yes, it is. So to wind up this discussion, I decided to come up with something that will always help you on how you are going to use this medication in terms of to help you in making that decision. And I've given it my name because I think at this point I can. So it's called the Ombu's decision tree. Okay? So in this Ombu's decision tree, I'm going to teach you how you're going to use when you're going to need this insulin. What are you going to check to help you in making that decision? Number 1, does the patient have a high hypoglycemic risk? That's the question you're going to ask yourself. Okay? Is this patient on multiple medications that can increase that risk? Is this patient, do you have history that this patient is elderly and maybe have all these issues that can increase their risk? If the answer is yes, consider insulin degludec. If the answer is no, is their daily routine variable? If the answer is yes, then consider insulin degludec because it offers you a flexible dosing approach. If the answer is no, does the patient have the support and tools to self-titrate? If the answer is no, then consider insulin degludec because it's a simple thing to use. If the answer is yes, then you can still use a standard-based insulin and is reasonable to be used like that. So thank you for listening to me. I have been privileged enough to introduce this insulin to you. And I hope now you have the confidence of prescribing this insulin because I've shown you the science and I've given you an Ombu's decision tree to use when you're stuck.
Thank you so much, Dr. Mbui, for that great information on insulin degludec. Are you getting excited? I want to call upon all the presenters of this morning forward so that we can have a Q&A session. Please prepare to ask your questions because we are chasing time. We may just have one question for each presenter. So before you even settle down, my first question goes to the first presenters. I know most of you are not here, but we could give you a take home. Dr. Rosie, when exactly do you screen for diabetes in pregnancy in our setup, considering that women will come in their third trimester, others will come when they think that they're expectant? When do we screen? Thank you.
Thank you, Kelly. That's a very good question. So we are moving away from just universal screening because what we've realized is quite a number of these patients come, they've had 4 or 5 pregnancies. You look and you find that they've had macrosomic babies. They have a very strong family history. They actually had complications during delivery. So what we are saying is that any pregnant woman who presents to you, if you manage to get them in the fasting state, do a fasting plasma glucose. On the other hand, If you have access to an A1C, then we'd suggest that you do that. And this is evidence from the STRIDE trial. Now, the STRIDE cohort, they actually picked 7 centers in India and another 7 centers in Western Kenya. And what they found was when they subjected these patients to either a fasting plasma glucose, point of care A1C, and then those who were actually followed up and at 24 weeks were given the oral glucose tolerance test, they found that up to 30% of the women actually had early GDM and had been missed or would have been missed had we waited for universal screening at the gestation of 24 to 28 weeks. Now, we know realistically in Kenya, because of the cost implications, we say then it's difficult to subject it to everyone. But what we are saying is, if you even get a random blood glucose, it's above 7.8, start thinking. If you have a fasting glucose of between 6.1 to 6.9, then that is someone you'd actually subject to your oral glucose tolerance test. Supposing someone has come in a non-fasted state, then now we're suggesting the 2-step process where you can give them 50 grams of glucose and you find your sugar is above 7.5. That's a patient you tell them, come tomorrow and we do the oral glucose tolerance test, because this is why our prevalence is projected to rise to as high as 589 million. I think we have been missing out on the women, especially in their reproductive age.
Thank you, Dr. Rosie. Do you have a question from the audience?
Yeah, okay. Thank you so much for the presentation. I'm Dr. Saumu from Tharaka Nithi County, Chuka Hospital, a pediatric endocrinologist. Thank you, Dr. Gaman, for your presentation. And I just want to share our experience in early screening of type 1. Just very quickly, we received a twin in DKA, severe DKA, and this child was 9 years. And what we did after we stabilized this patient, we talked to the family and we decided to screen the twin. And when we did the autoantibodies, we actually found that the Kdsg was very high in the twin. It was at 2060. And this has actually helped us follow up this patient. So currently we are at stage 1. The blood glucose has remained stable. And what we are doing, we are following up this patient, watching out for any symptoms, and also monitoring the sugars every 3 months. And then I wanted also to comment on neonatal diabetes. In the country, we've actually had infants presenting in the first 6 months of life. And our biggest challenge has actually been doing the genetic testing. And I remember one of the patients that we were able to diagnose, it took a long time because we had to send this test to the UK. And when they came out, we found that this baby had KCNJ11 mutation. And actually, because after making this diagnosis, we were able to transition this patient from insulin to sulfonylurea. And currently we are on glibenclamide, and the patient is doing well. And I'm so happy that now we are able to do genetic testing in the country. And the question to Dr. Rabia is, how much is the cost in the country? Thank you. Yes. Oh, I'm being told to introduce myself. I'm Dr. Winnie Saumu. I'm a pediatric endocrinologist working at Chuka County Referral Hospital, Tharaka Nithi County. And as you can see, whatever Dr. Gaman and Dr. Rabia they have talked about actually is possible even in the counties. As long as you have the information, you can actually request for these tests. Thank you.
Hi. Thank you for that question. And yes, we can test genetics here now. Samples from the county can come in to Nairobi and it can be tested. So the cost of the test is not as expensive as it used to be. Let me start there. We're talking of over hundreds of thousands of shillings before, but now you can pay the standard rate at DKL is about between 53 to 63,000 shillings for single gene analysis.
Thank you. That is encouraging because we learned that the tests are available locally and the timing is what? Shorter to get your test. So you can do the test because you are now informed, you are incited. Remember, we were told by Dr. Gaman not to react to what? To type 1 diabetes. We should manage it. Now, my question goes to Dr. Gaman. Is there a role for verapamil in preserving the beta cell mass in a type 1 diabetes?
Can't remember that. There was something there. Anyone can help me with that?
Yeah, so there have been studies actually looking at the role of verapamil in preserving beta cell mass. And just like teplizumab, last year actually at the ESD, there was a study that was presented which looked at both the teplizumab and verapamil. And they have not found enough evidence to recommend verapamil for prevention or preservation of beta cell mass as yet. So there's a few studies that showed, but longitudinal data has not shown definite benefit in delaying the progress.
Do you have more questions from the audience? Yes.
Good morning. I'm Dr. Parag Patil. I'm a consultant physician in Eldoret Hospital based in Eldoret. My question is for Dr. Davis Ombui. We talked about degludec a lot, and we already have a once weekly insulin available and approved in the country last month only, March 2026, which is a weekly having icodec. And there is another once weekly insulin which is coming with a better mechanism of action, FC-TORA alpha. So maybe I would like you to talk something about this, and maybe once they come here, you might need to change the Ombui's decision tree.
Well, we have insulin icodec that was approved, but it's not yet into circulation. Basically, to tag on along Dr. Gaman's presentation, you will always get newer molecules coming into the market. And the idea for that is at the end of the day, it will be patients who will be benefiting from this kind of treatment. Remember, managing type 1 is challenging because of this issue of multiple daily injections. If you can reduce the amount of injections that these patients get, you tend to reduce their diabetes distress and improve their quality of life. So I'm looking forward to insulin icodec coming into the market. I hope I'll make another decision tree for that. But until that, we can only speculate because look, it has taken 10 years for degludec to get here. We don't know how long it's going to take for icodec to be here. So let's just be hopeful and wait for it. That science, we'll talk about it when it comes.
You have a question there?
Good morning. Thank you all the presenters for those insightful presentations. My question goes to Dr. Obui again, and this is concerning the degludec. I'm just concerned in like, if a patient gets hypoglycemia, and we are already having some deposit of like 50%, how would we help or empower the patient to know how to titrate to ensure that they don't have a recurrent hypoglycemia and also be sure that they are not going to miss out a dose and they end up in hyper. How do we titrate? A patient has come, maybe we have given the doses like in 2 days' time, and now they report a hypo. How do we handle that? Thank you.
I think I wanted to add on something with the question there. I showed you a slide that talked about when glargine was introduced to the market. I have a slide on our developments in Kenya, and we weren't far behind those days. It would be 1 year, 6 months. And this is a challenge maybe to the farmer, that we really need to rethink our strategies for Africa and other countries where we have products taking so long to come into the country. And that's why Umbui was complaining, I was also complaining, that we can't wait for this long. If people can pay for it and it's available, everyone has the right to that product. And I think maybe this is something that I would like to say that the farmer needs to take back to their head offices, that we too deserve a right in getting these products as soon as possible.
Yeah, you've asked a good question about the risk of hypoglycemia when you're on degludec. As I had shown you in the presentation, the risk is lower when you're on glargine, okay? But the risk is still there. The question then is, how do you assess that risk and how do you manage a patient who's come in hypoglycemia? Number one, always suspect the medication which confers a higher risk. So for example, if a patient is on a basal bolus, always suspect the basal first. Number two, if you have technology that could be helping you, now we are having quite a variety of CGMs in the market. If a patient is on CGM, it can actually also help you think about what could have been the cause of hypoglycemia in this patient. Number three, remember there are many other issues. So it could be maybe a missed meal. It could be some form of other medication that the patient is on. And what I wanted to say about degludec, because that risk is still there. If you remember, then nearly at the end of my slides, I showed you how degludec works. It's hexamers that when they are deposited into the system, into your subcutaneous tissue, the rate of breakdown into monomers is slow and progressive, in that at any particular time, you always get half of what is there into the circulation, okay? And it's a peakless kind of insulin. So you wouldn't expect much of it to come because of the insulin degludec. Much of that would really come with the interaction with the other medications that the patient is on. So for example, the basal insulin, maybe the patient is on SUs, maybe there are meal issues, maybe the carb counting is wrong. Those are the issues that you need to know about. Now, in the issue of titration, now remember I said for you to achieve steady state, you need like around 3 days for you to now get the steady state of the insulin into the system. Now, how do you titrate basal insulin? You are looking at the fasting blood sugar. And the fasting blood sugar will be able to tell you if you are underdosing or overdosing, okay? And in our practice, we tend to take 3 to 5 days to make that decision. You don't use just one reading to make that decision to titrate the insulin. Remember, there are things that can help you. Weight can help you. Carb counting can help you. So there you have tools with you that can help you to assess how much of insulin you're going to use, especially for the boluses. And for the basal, the fasting blood sugar will help you. Every 3 to 5 days, you can go up 2 units or down by 2 units. Thank you.
Thank you, Dr. Ombo. We'll have
Can
one
I just add one thing? I think her question was, a patient has a hypo at that time, and then, so he answered your question. Just think through, the dissociation is very slow. So if I have a hypo and I'm on degludec and I bring my sugars up, If I have, let's say, rapid insulin or glargine, my risk of a hypo is faster with the same amount of insulin as with degludec, because degludec will take longer to come into this, as Ombui was saying. So your risk is actually lower.
Dr. McKenna, how long do you follow the women after they had diabetes in pregnancy? How long do you want to be with them and work with the endocrinologist in surveilling for diabetes once they have had their babies? And then we close.
Thank you. So once they have had their babies, the guidelines recommend we do OGTT at 6 weeks. That is to determine whether now they have type 2 diabetes. And then at that point is when we refer them to you now for long-term follow-up.
Thank you. The session is closed. The presenters are still with us and you can interact with them. Thank you. Is there a group photo? Please be back at 11:30 after your tea. Yeah, 11:30. 11:20. 11:20, you come back for more exciting presentations. Thank you.
God, now my protection, love is a connection. I'm meant to be here. Before something comes, it is what we love. Never feel you almost. Alhamdulillah, praise be to God, no matter your condition. Everything you do.
So here at Kdsg, our main focus, our main mission is to ensure that we have a country free of complications of diabetes. And how are we going to achieve that? By training healthcare professionals with regards to diabetes and its complications. And that is why at every annual conference, we bring in specialists in various areas when it comes to the brain, to the heart, to the kidney, so that we can be able to amalgamate all these specialists together with our nutritionists, with our podiatrists, and with our nurses, so that we are able to enrich this knowledge. And through this, you can be able to actually collaborate with the different societies and then get to know all the trainings that we're running throughout the year with regards to diabetes. Diabetes is constantly changing. Where before it was all about glucose, now we have stopped looking at the numbers and we're looking at what is the molecular biology behind that. And what we are finding is now we're collaborating with obesity specialists because we find that if you've got an obesity
to join you today at this important scientific conference and at the timely theme, the evolving face of diabetes and metabolic health in Kenya, from prevention to precision. Allow me, on behalf of the ministry, to congratulate the Kdsg for bringing together experts, practitioners, researchers in this conference to ensure that we can be able to focus on
Okay, I think we'll start the mid-morning session.
researches
You're all
that
welcome
can be able
back.
to be localized to inform future policy
So,
Our focus for this morning and today has been on obesity and metabolic health for that matter. So we have looked at the rates of obesity, the global increase in obesity, and not just the global increase,
So
but
as we
also
continue
the
with our
regional and
session,
Kenyan increase.
I
The
want
statistics
to
are
welcome
startling
our
because the
first
rates are
speaker
expected
for
to
the
increase
mid-morning session,
rapidly in low and
and is a
middle income
gentleman
countries
who
where
needs
our
no
country falls.
introduction.
And not
He's trying to create his own policies, decision trees. So I will welcome back Dr. Umbui, who will come and give us a talk on point-of-care testing and how it empowers preventative patient pathways. So welcome, Dr. Umbui.
I hope you've enjoyed your tea, and I hope I'm not going to be boring now because this is the second talk I'm going to give to you. I've not had a change of clothes, it's the same me. But I want to start this talk by giving you a short story. Once upon a time, I worked in a level 3-4 facility in Muranga. The level facility is actually called Muriranja Sub-County Hospital. And because of the increased prevalence of diabetes and alcohol-related issues, we used to tend to get a lot of DKAs in that setup. Remember, this is a level 3 hospital. When I would come in to do the round as a physician, all I would have with me was a random blood sugar. No electrolytes, nothing. Number 2, I would only tend to have Actrapid as the insulin. And number 3, the glucometer was shared between, I think, was it 4 wards or something? So the glucometer is here, it goes to OBSGYN, it goes to, I don't know, another place. And we really never used to have really good outcomes for patients who we were managing for DKA. And this talk today is just to bring the issue of point-of-care testing as a subject of discussion and to see how we can use such diagnostics to help us improve the care of the patients who come to see us, whether inpatient or outpatient. These are my disclosures. Is it working? Oh, we can go ahead. So I have given lectures to those. But I think the most important thing now is to see what is the challenge that we are having. The biggest challenge we are having right now, and as most of you have already seen, is the rising burden of disease. As the burden rises, the challenges of managing this condition also goes up. You tend to have many patients, your turnaround time is an issue, you have pressures to make diagnosis, you have pressures to make treatment. And the impact of that is if you delay to make a diagnosis, then it has an impact on the progression of that condition for the patient. For example, a patient who has DKA and you delay in making that diagnosis, the mortality, you might face mortality issues, you might face complications issues. So having things that can help you make those decisions at that time is something that is of importance. And we have these gaps, and that is the reason why I started with that story. Because I'm privileged now to work in an area where these diagnostics are there in front of you, and you can easily access them. And I know most of us come from many places whereby the challenges that we're facing with diagnostics are real, as I've given you an example. And part of the solutions that we now tend to look for are, can I make real-time decisions? Can I make a real-time diagnosis? Can I know you have diabetes right away? If I'm to walk into this group right now with a kind of a diagnostic test that I can use here, can I make a diagnosis in real time? And that's the biggest question that we are facing. So then what is point of care testing? So this is testing which is near to the patient, and the results are within minutes, okay? This is not a central place where you're taking these samples for you to get the diagnosis. It can even be within your office. So that is what is meant by point of care testing. And there are many types of these tests. We have things that you can hold with your hand as diagnostics. We have benchtop analyzers that you can put in your office. And we even have wearable things these days that can help you in making that diagnosis. And in the space of diabetes and endocrine space, these are things that can be used to measure your HbA1c, your random blood sugar, your ketones, your thyroid stimulating hormone, your vitamin D, and your blood gases. And you can see how this now comes up to help you with these issues. Then why does it matter? The reason why this matters is because now that reduces your turnaround time. I want you to imagine you are in a clinic where you have a long queue, and each patient is waiting for you to make a diagnosis. The longer they wait, the less is your revenue, the less is the time, the more the time you are wasting to make key decisions on your patients. So if this point of care testing kits can help you reduce that turnaround time, then it's something that we should embrace. And to add on that, it improves, the patient flow. You can imagine that queue that you have, and you can easily make a decision as you move on. And it offers you can imagine you are here, for example, in Nairobi, and a patient has come from somewhere which is maybe 200 kilometers from here. If you can be able to give closure to that patient by giving them the same day results, they look at you, they look at what they have presented to you, and you get to have the results the same day. Give them closure, give them an opportunity to know how they are going to manage their disease going forward. These are things that are subject to consideration by all of us as clinicians. And I think that challenge even is faced by the big hospitals. There are these tests that take a turnaround time of 10 days, and someone has come from an outside country, and they may be here for 48 hours. There are diagnostics that are available that can help you, lower that turnaround time for you to make that decision. And it improves outcomes for a patient. You can imagine if you can make that decision at that point in time, and it can narrow down to a diagnosis, and it can narrow down to helping you make the right treatment choice for that patient. You can imagine how that outcome is going to impact on that patient that you are having. A patient has come, they don't know, for example, which type of diabetes they have. If you have a C-peptide, for example, that you can do within 2 hours, and you can make the patient understand. So these are some of the things that I think we should be a subject to discussion. Now, there's great success, and I think in the field of diabetes and endocrinology, most of you actually know this, that one of the things that you can now see in our clinics is measurements of capillary blood glucose at the point of triage. And I am sure at many centers where you are, that is now something that you are capable of. That random blood sugar can help you make a decision. For example, a patient can come to your outpatient clinic and you get a random blood sugar of 24. You know the next step is Maybe you need to do your ketones, maybe you need to do further blood work, maybe an HbA1c, maybe a blood gas, things that can help you hasten that decision for that patient. The other thing is the HbA1c. The turnaround time has now come to something that is considerable for you to make a decision. In some good places, by the time the patient is coming to the accident and emergency, by the time the patient is going to the ward, you already have your HbA1c to help you in making the decision. The other thing is ketones. And I think in the market, we've now had quite a considerable number of ketone meters. And even for patients who are going to be managed at home, for those patients who you know are at high risk of DKA, for patients who are on SGLT2 therapies, for patients who are type 1 diabetes, we are now empowering these patients to understand that they can measure their random blood sugar, and if they see it's at a certain range, they can even use now ketone meters to make that decision and understand, are they in ketonemia or not, and what decisions are they going to do with that. Even at the level of the clinics, you get that random blood sugar that is high, you can easily measure ketones there and make a prompt decision on how you're going to manage that patient. We've come to the era of CGMs. They are here with us now. I'm sure some of you here have that or have used it or experienced it. These tools are now with us. We are giving to our patients. They can be able, they can learn how to use them. It can prompt them when the glucose is going low. It can prompt them when the glucose is going up. They can now understand on what to do about their blood glucose. And these are the decisions that they can make away from you as a healthcare provider. And some of them are actually integrated with AI, and it can even advise them on what to do. So you can see you're getting less and less important when it comes to managing these patients, as your decisions are not as valuable as they used to be a long time ago, especially in the space of AI. I'm not saying that you will be out of work. I'm just saying that these things are going to help us manage patients. Both of us are going to benefit. Now, when it comes to diagnosis and monitoring, you know where now you use your HbA1c. These decisions are there with you. It can help you adjust therapy. It can help you to do screening. And I think for part of the things that we've been doing, part of the education that we've been doing to our patients is even for those patients who are at risk, an HbA1c can actually help you make that decision. Is this patient pre-diabetes? Do you need to do further analysis on this patient to help you make a decision? And even in intensification, we know that there's clinical inertia. Titrating that treatment for your patient is paramount to what labs you have with you. If you have an HbA1c that you did 3 months ago, for example, it was 7%, and now it is 10%. It can help you. That HbA1c can help you to know, what do I need to do for this patient to help them manage their glucose better? Now, I'm going to focus a bit more on the HbA1c. HbA1c is glycated hemoglobin. The blood sugar, the glucose coats on your red blood cells, and you know the lifespan of the of the red blood cell is how many days? Come on, you can shout it. I'm hearing 90. Is it true? 120 hours or days? Days. So with that decision, you can be able to monitor that glucose that has attached to the red blood cell, and it can tell you how long. You can go back retrospectively and check how well managed the sugar has been. I know there are challenges with that, but today, let's just consider the goodness of this test. One of the things is you don't require a patient to be in a fasting state. The patient comes to you in whichever state that they are in, and you can be able to get an accurate test. Unlike other tests that you need the patient to come at a particular time. The other thing is this test has good pre-analytical stability than the glucose itself. So that is why sometimes you measure glucose now. A random blood sugar might not be the best to tell you how the glucose control has been over the time. So this is one of those things that can help you. And it's not affected by the acute changes that you get. The patient has come with other comorbidities, maybe an acute infection, maybe trauma. They don't tend to affect that. So across a myriad of conditions that this patient is presenting with, this is still a stable test for you to do to make a decision. And how is it done? You are the healthcare professional. As you can see, you do a finger prick test. It's as simple as that. And these are the patients maybe who are at risk, or the patients who you are doing a follow-up. And you can see if the HbA1c is less than 5.7, it doesn't tell you much, it just tells you things are okay. If between 5.7 and 6.4, it tells you this patient might probably be pre-diabetes, and you may subject this patient to further tests. And if the HbA1c is above 6.5, then it confirms for you the diagnosis of diabetes, and it prompts you on what you need to do next. The same thing, in terms of glycemic control in individuals with diabetes. It helps you make that decision. If you had this patient who had a certain HbA1c at the point of contact for the next time, how it has changed can help you know, do you need to escalate care? Do you need to de-escalate care? It's something that can really help you in making that decision. Remember, clinical inertia is a big issue. There's what the patient contributes to it. There's also a lot to what the professional, you, the healthcare provider, contributes to it. If you can have something in the middle that can help in that, embrace it. Now, we also have things like the CRP. So patient has come, you're suspecting maybe they have an inflammation, and you can actually do it at the point of care. And you can know if this thing is going to help you in making a decision in terms of testing. Now, we know how we've used these things. These point of care things are applicable for management of decay, for management of HHS, measuring your ketones, measuring your blood gas, and and these things is not just at the point of measuring, it's also at the point of monitoring. So they can help you know the diagnosis, and they can help you to monitor as you go forward. There's also the thyroid issue, and I'm sure many of you here who have managed thyroid patients, there is a problem with standardization of these tests. You will get one lab giving you these values, another one giving you certain values in different parameters, in different measurement categories. If you can be able to measure these things, and when it comes to the thyroid illness, a TSH is something that is very sensitive. It can help you know if this patient is hyper or hypothyroid. And once you just have that TSH, you can be able to know what you need to do next. And the problem with this is because you see, thyroid disease is not something that will give you very conventional classical symptoms that can separate those symptoms from other conditions. So patient might just be coming with fatigue, and if you just measure TSH and you see it's deranged, it can help you in making that decision. Now, in reproductive health, we've seen the use of HCG in making the diagnosis of pregnancy. We've seen the use of LH for ovulation testing, and now in the new polymetabolic endocrine syndrome, the things that can help you in making that diagnosis, we have the criteria, all of you, maybe some of you know. And these are the things that can help you in making that decision. In terms of bone and calcium disorders, these are some of those conditions which we've not impacted much in, especially in our practice. We tend to overlook such issues until a patient presents with either fragility fractures or maybe other conditions that affect the calcium, is when we are looking into these things. I know it's a challenge in some situations, but where applicable, where you can quickly measure your calcium, where you can quickly measure your vitamin D, These are the things that can help you make quick decisions for patients who have osteoporosis, patients who have parathyroid disorders. They can be of help. Now, beyond emergencies, we have things like adrenal crisis. Can you measure your cortisol? Apart from the clinical information that you have, are there things that can help you make that prompt decision? Because that's the only time you have to make that decision on how to manage this patient. Things like a thyroid storm, as much as they are rare, you can imagine what difference that point of care testing can do in making a decision on how you're going to manage that patient. And things like myxedema coma. And as I'm finalizing this discussion, I think they highlight to me how your sugar was when you were running or when you are doing any activity. And we are getting closer. And I'm sure Dr. Njagi had told you here, is Dr. Njagi here? She had told you that a place like Muranga is now doing teleconsult. You can be able to reach out to people who are far away and offer them services from a place where they could not have afforded to reach or get access to. And number 4, cloud-based monitoring. I think to me that's a very interesting concept. That you can be where you are, it doesn't matter. But so long as there is internet, we can cloud connect and I can get your information from the cloud, from where you are connected, and I can be able to make important decisions based on what data is available to you. So, as we finish, there are challenges that come with these things. As much as we are touting how good these machines, these diagnostics are, there are challenges with analytical performance, quality control, training, cost effectiveness, and governance. There are things that go beyond you as a clinician. There are things that go to quality control. There are things that go all the way to the governance level. And I think it is upon us to be sure that when you're getting these point of care testing machines, you have to be sure, are these things, are they able to give you reliable results? Are they things that have been registered for use? And that is why now you're seeing mushrooming of many other diagnostic places. And it gives you sometimes, the fear that you might actually be using results that are not as credible as you may want them to be. Now, this is my take-home message for you. The point of care testing has actually transformed our space. It has come a long way. We have now embraced this, and we know the outcomes that it has given us. As much as there's many other success stories in many other fields, we, the people who are here, have known how that has transformed the field of diabetes. We are now be able to make decisions promptly, and we are now able to reduce the errors that we used to make when managing our patients. And now we are getting into that space where there is expansion of these things because of connectivity. There is data, there is cloud, there is AI, and all these things are now getting incorporated into all these things to help you make decisions faster. And the future is personalized. I think to me, that is something which is the next frontier in medicine. That no two patients are the same. In terms of their genetics, in terms of how they handle their condition, in terms of how they handle their medications, the future is going to be personalized medicine. You might find a patient who responds better to metformin because of their genetics. You might find another one who responds poor to GLP because of some genetics. We are going to that space. And I think when we'll be having such a talk again, maybe 10 years from now, this will be a very different kind of conversation. Thank you so much.
Thank you, Dr. Ombui, once again for that insightful presentation. And I request that anyone who has any questions, you can write them down and we'll do the Q&A at the end of the session. Next, I want to invite Dr. Mzee Ngunga. And Dr. Ngunga is an interventional cardiologist at Aga Khan University Hospital, Nairobi. He's also the head of the Cardiology Fellowship Training and the head of CCU at the Aga Khan University Hospital. He is also the current president of the Kenya Cardiac Society, and he's a researcher with interest in cardiovascular disease, especially the acute coronary syndromes and heart failure. And he is actually the chief researcher in the Kenya Heart Registry. So for the next 30 minutes, Dr. Ngunga will take us through when sugar beats, rhythm, pain, and failure. So welcome.
Thank you, Dr. Ari. So for the next 30 minutes or so, I'll talk a lot about the heart. I don't even know who gave me this presentation. I think it must be Eric. So when sugar beats rhythm, pain, and failure, so for the longest time, the face of diabetes was hyperglycemia, but I believe after so many years, the face, that probably remains the face. Diabetes has many parts, the head, the brain, the trunk, and hyperglycemia is not the only problem, but kind of talking about the sugar here. So let's see, I have no disclosures regarding this particular presentation. And this is coming out of your own research from diabetes. I got this slide from one of Dr. Njenga's slides that in the adults above 20 to 79 years of age, diabetes is 1 in 10. That's a very high prevalence of diabetes. And 1 in 18 may have impaired fasting glucose. So these numbers are kind of staggering. I was talking to a colleague who was sitting next to me, that diabetes world is kind of really is mushrooming and kind of becoming very prevalent. So something needs to be done. Nonetheless, from the cardiovascular point of view, we kind of tackle the complications arising out of diabetes and sometimes out of its treatment, because sometimes if you control the sugar very well, then other problems kind of crop in, or indeed the longer the patient lives, then other complications crop in. So this is studies coming from around the world telling you that the prevalence of cardiovascular disease in diabetes is in the range of 20 all the way up to 60%. That means anybody with diabetes, already there's some cardiovascular disease. So whether it's a beat, the pain or the failure, that kind of story, you're going to find it in one of those patients. And this is local data coming out of one of our residents from our program. Actually, she looked at dysglycemia. That means impaired fasting glucose, or I don't even think you can read what's on those slides over there. So this study showed that actually the rate of new diabetes is quite high in those patients who are already presented with cardiovascular disease. Probably 10% of patients who come with a new MI and new stroke will probably have new diabetes, and this is quite high. So she looked at 211 patients and she found that dysglycemia was present in 68% in all those new patients, and some of it was new actually. Half of those patients were new diagnosed. Now, this is what we see every day. Some people come to the doctor with heart attack, to them, oh, your heart is not the only problem, you also have diabetes, and the kind of the problems keep accumulating from there. So these are some of the things we want to prevent, and maybe there's a long way ahead. So diabetes problem causes these complications long before even the diabetes is diagnosed. And these are some of the challenges that we probably need to talk about. So I'll spend a few minutes talking about atherosclerotic cardiovascular disease, because I was talking about the beat, the rhythm, and the failure. So this kind of tackles the pain part. So because of diabetes, we all know about the story of oxidative stress caused by hyperglycemia, inflammation, again arising out of it, endothelial dysfunction, endothelium mesenchymal transition, and epigenetic changes, which Dr. Ombui has just talked about, is one of the things which, after many years of being exposed to diabetes, you get development of atherosclerosis, and this is eventually what causes heart disease. So if you look at this particular study, again, there are many, many forms of atherosclerotic cardiovascular disease, and we are talking about peripheral artery disease, strokes, MIs, and if you look at the number of, if you match the controls, is almost doubled. So any person with diabetes, the rate of atherosclerotic is actually doubles compared to the matched controls, all the way from PAD, strokes, and strokes looks like it's even much more common, and even myocardial infarction in all patients with diabetes. So it is true any patient with diabetes, that milieu of inflammation and the oxidative stress keeps this process going on. So this study is also coming from our hospital. The prevalence of diabetes, again, out of the patients with STEMI, 43%. So it's not just, so diabetes patients are overrepresented in patients coming to the hospital with acute coronary syndromes. And indeed, we also looked at young patients, people who are less than 50 years, presenting with acute MI. What's the prevalence of diabetes? It is quite high as well. And you can see again, if you look at the categories, ethnicity and the diabetes, hypertension, 56%, diabetes, 58%. So in young people, the prevalence of that is even higher. That means if you have diabetes as a young person, the chance of anemia is even increased. And this is approximately 58% in the overall cohort. This study is also looking at the burden of heart failure, which is the other part of diabetes, which is the failure part. The caliber of heart failure among people with diabetes, this study looked at 1.9 individuals, 30 years and above, and out of them, a lot of them had diabetes, follow-up of around 5.5 years. The prevalence of heart failure was 14%. Many of these patients' heart failure is due to multiple causes. We have talked about atherosclerosis, we have talked about diabetes cardiomyopathy, we have talked about the heart rhythm problem, so we'll see which part contributes a lot to this patient's development of heart failure. Diabetic cardiomyopathy, there before it was a subject of a lot of debate. People used to wonder, how does diabetes cause heart failure? Indeed, it is true. Once people develop diabetes, they start developing oxidative stress, they start developing cellular dysfunction, then this myocardium fails. So there before, we used to think every patient with diabetes has occluded coronary arteries. Indeed, it's 50-50. Many of those patients who have diabetes and heart failure, half of them will have ischemic heart disease, and the remaining half will have what we call diabetes cardiomyopathy, which is basically heart muscle dysfunction due to prolonged hyperglycemia and oxidative stress and myocardial dysfunction causing this kind of myocardium that we are seeing here. So LV dysfunction is often undetected. Again, this is a study done just looking at simple changes or early changes which occur in the myocardium long before the patients get symptoms. And what they found is that 68% of patients with type 2 diabetes had LV dysfunction 5 years after type 2 diagnosis was diagnosed. And what is the commonest? So you will find 32% had normal LV systolic function, 16% had diastolic dysfunction, and systolic dysfunction was 20 was another group, 27%, and if you combine them, 25%. So these changes occur very, very early, and tells us that when we are treating diabetes, it is true, sugar is one of the problems, but now we do know that you have to go beyond the sugar and treat all these metabolic complications which are part of diabetes. So if you look at the undiagnosed heart failure was found in 28% of patients with diabetes during the cardiac screening, and of which heart failure with preserved EF was the most common, 23%, and heart failure with reduced EF. Indeed, the element of what we call diastolic dysfunction, you will see this a lot in your echo reports. Diastolic dysfunction is almost invariable in your diabetes patients. So if you send those patients for echo, you'll find, oh, already something is happening. That means something needs to be done in that patient to prevent the progression of the heart failure. So this is a prevalence of diabetes in heart failure patients. Again, so this is kind of the opposite. So patients have come to the hospital, they are found to have heart failure. What is the prevalence of diabetes? Again, the number is quite high, okay? 25 or almost a quarter of them will have diabetes. Why? It's a dual causation mechanism, and also coming from a heart study in Kenya. We look at the prevalence of diabetes. Again, look at it there. This was 14.7% of diabetes in the heart failure patient. What is the mechanism? So diabetes and heart failure subtypes, so you can group it in glycemic subtypes and also glycemic status. So those people who have heart failure with preserved EF actually tend to have even much poorer survival. So once the patient has diabetes and the heart starts getting weak, whether it is heart failure with reduced EF, heart failure, then the mortality in that patient continues to increase dramatically compared to their counterparts who don't have diabetes. And the same applies to the pre-diabetes group. So, but the one which is more significant, as you can see in this chart, is the diabetes group. So what are the mechanisms? How does heart failure cause diabetes? And it's a very good question. And you can argue, this is where you're saying, well, I came first, but it is true. Who came first, the diabetes or the heart failure? So it is true. If you have heart failure, indeed, you can get diabetes. But let's look at the other side first. Diabetes is a risk factor for heart failure. The risk of heart failure with diabetes is seen to be higher in young adults and women. I showed that very clearly in people who get heart attack very early. Poor glycemic control adults greater risk of developing heart failure. And each 1% increase in HbA1c, the risk of heart failure goes up by 8 to 36%. The risk of heart failure among diabetes increases with older age, coronary disease, PAD, microvascular complications, and the neuropathy, don't forget neuropathy, longer duration of DM, obesity, hypertension, and higher levels of NT-proBNP. On the other hand, microvascular disease, heart failure, and type 2 diabetes, again, if you look at microvascular dysfunction, these are the patients who tend to get more heart failure. If you have microvascular disease, telling you the problem is not in the large vessels, it's actually in the small vessels in this patient, and that's where the issue is. So no microvascular disease, the risk of diabetes is less than 2, but with microvascular, it actually triples. You can see almost 6%. So heart failure is a risk factor for diabetes, very, very important. How does a patient with heart failure get diabetes? It's a kind of scaring phenomenon, but the metabolic impairment is intrinsic to heart failure pathophysiology, and insulin resistance is present up to 60% of heart failure. When people develop heart failure, you get reduced organ perfusion. And amongst people who have non-diabetes with heart failure enrolled in the CHARM and emphasis heart failure trial, the prevalence of incident heart failure among heart failure included elevated body mass index, history of smoking, elevated glucose HbA1c, systolic, higher blood pressure, longer duration of diabetes, and diuretic therapies, and also higher New York functional class. So it is true, pathological mechanisms include endothelial stress, apoptosis and fibrosis, basically renin-angiotensin system impairment, cardiovascular autonomic dysfunction, that's actually really, really important, mitochondrial dysfunction and oxidative stress, inflammation and altered insulin signaling, metabolic lipotoxicity and increased fatty acid utilization, and microvascular disease. Those are some of the important mechanisms how people with heart failure eventually develop diabetes. And hyperglycemia, as we said, again, is a very, very important element. I talked about calcium handling, insulin resistance, increased lipid uptake, glucotoxicity, and abnormalities in the renin-angiotensin system with progressive fibrosis, apoptosis, and abnormalities in the mitochondrial function. So morphological subtypes and phenotypes of a diabetic heart, this is really, really important. This is what we see when you do a post-mortem in those patients who die of what we call diabetes cardiomyopathy. Coronaries, you say, are clean. But why is a patient having heart failure? And indeed, the pressure could have been normal. So these patients have very aggressive cardiac fibrosis, which we see on the histology, and sometimes you can actually see it on the cardiac MRI. Cardiac hypertrophy, where you get cardiomyocyte hypertrophy and increased LV mass, and impaired coronary microvascular dysfunction. If you do a nuclear scan in these patients and you do an FDG uptake, you'll find it's completely abnormal long before they get heart failure symptoms. So diabetes and stroke is another part that I also talk about. So again, diabetes is a risk factor for both ischemic and hemorrhagic stroke. And pre-diabetes and acute stroke, again, remains a very, very important element. You saw the study done by the resident in our hospital showing very high percentage of new diabetes, even in the people with stroke. So ischemic stroke and TIA is a prospective cohort on 9 months glycemic status classification. What they found was that even the pre-diabetic state itself was a risk factor for stroke and TIAs. And what this study, which is a very large cohort, age was a very important factor. The stroke severity was very important, and even the premorbid conditions in the CHA2DS2-VASc score that we'll talk about. Diabetes and the heart rhythm disturbances. So again, this includes the commonest heart rhythm disturbance we see in our hospital is atrial fibrillation. So atrial fibrillation, if you look at this chart, anything you see up there is a prevalence of all manner of heart rhythm problems. They include PVCs, PSCs, atrial fibrillation. They are much more common in people with diabetes. So anything you see on the red there are patients with diabetes. I think on the top is intraventricular conduction disturbances, VT, much more in people with diabetes. Why? Microvascular dysfunction, oxidative stress, and all the problems that we already talked about. So diabetes causes structural remodeling, inflammation, oxidative stress, and glycemic fluctuations. And this causes reticular remodeling and autonomic dysfunction. So these are all very good milieu, particularly for atrial fibrillation, which tends to be very prevalent in people with diabetes. prognostic significance of diabetes in hospitalized patients with atrial fibrillation. Does having diabetes make your atrial fibrillation worse? That's a very good question. This is a retrospective cohort study looking at 1,000 patients discharged from the hospital with the atrial fibrillation. They looked at those and those without diabetes. What they found was that all-cause mortality for those people with atrial fibrillation was much higher. Look at the all-cause mortality. So let me just go back. So the all-cause mortality was much increased in those people who have diabetes. Cardiovascular mortality was much increased. And if you look at stroke and cardiovascular mortality, again, much higher. Even sudden death, much higher in those people who have diabetes. In a cohort of patients discharged with atrial fibrillation. So talking about the BIT, again, diabetes patients always fare off worse. So comparative outcomes of AF patients in people with and without diabetes. The only thing probably which does not get worse is atrial fibrillation progression, which kind of remain the same, but everything else, mortality in those below 70 years, above 70 years, cardiovascular death, non-CV death, all of them tend to be worse in patients with diabetes. So are there any treatments? So in the era of diabetes for a long time, doctors used to look at HbA1c. They used to look at reduction in sugar control, but eventually these patients get all these complications we are talking about, which are beyond the sugar. Some of them brought about by this abnormal lipids. Are there any treatments which reduce cardiovascular mortality, particularly the AFib, the atherosclerosis? And that's a very important point. And I think since the rules changed regarding drugs for diabetes, we have seen a very, very big change regarding this. So SGLT2 inhibitors have been shown to improve many of those parameters that we talk about in diabetes. We saw this in the EMPEREG trial, which reduced cardiovascular mortality, and is approved for heart failure with preserved EF and heart failure with reduced EF, and it has more robust cardiovascular mortality benefits. And the same applies for dapagliflozin, again reducing cardiovascular disease, particularly heart failure, reduced EF, strong evidence in CKD, and wider approval in CKD irrespective of diabetes. So all these drugs improve diabetes, the sugar that we kind of want to say the face of diabetes, but there are many other parts, heart failure and low hypoglycemic risk. What other drugs have been shown to reduce cardiovascular outcomes beyond this is still talking about the two drugs, DAPA and empagliflozin. Again, if you look at propensity scored matching, both drugs performed quite well in reducing cardiovascular mortality, because these are the cardiovascular outcomes we have seen are the ones which will cause problem in your patient. It is true, some of you as physicians may think everything in diabetes is about cardiovascular, but when we are young doctors, it is true. Infections, we are leading on top, people getting all manner of infection because of dysglycemia, and also DKA. But DKA is kind of a new diabetes, but as diabetes progresses, cardiovascular disease becomes much more prevalent. What about GLP-1 analogs? These are new drugs which have shown a big promise in reducing the effects of diabetes, because they don't just work by reducing the sugar, they work through by altering the metabolic derangements in diabetes, cardiovascular events reduced by 14%, all-cause mortality by 12%, heart failure, and composite kidney outcomes. So these are the new drugs which have changed the face of diabetes, and I was just talking to somebody there, unfortunately, we will go where the science is. The science tends to be skewed, and it's kind of skewed towards the medicine. There are probably other therapies which can cause this, but we probably don't know them. So thank you very much for your time and for inviting the cardiologist to talk in a diabetes meeting.
Thank you, Mzee Gunga, for that talk. And now we'll go to our final presenter of the session. And this is Dr. James Adungo Ikol. He holds an MBCHB and MED in surgery from the University of Nairobi and a fellowship in urology from Mumbai. He's a urologist currently working at KNH, and where he also serves as the head of the urology unit. He's a former lecturer and department chair at Kenyatta University School of Medicine. He's also a member of the Kenya Association of Urological Surgeons, and he's currently serving as the vice chair. and is also a member of the Society International of Urologists, the European Association of Urology, and American Urological Association. And he will take us through the topic of erectile dysfunction and why being proactive is good. Welcome.
Thank you. Thank you very much for that. Thank you very much for that kind introduction. I am feeling a bit lost, having last sat with in a diabetics class in 1994. And my teacher, I was pleasantly surprised to meet my teacher in Ward 8A, Dr. Ngugi, here today. Even that time in 1994, it was difficult to learn diabetes. Listening to the last two speakers, it has become more difficult. I will start by asking each and every one of us to stand up. In urology, we like practicing what we preach, so you can march a little, hands up, down, up, down, up, down. Thank you very much for modifying your lifestyle. So, I was asked to talk about erectile dysfunction in diabetes. I must apologize, first of all. You guys are so much ahead in technology. In urology, we are still analog. So if I mix up these things, you'll forgive me because we are still analog in urology. But I think I'm acquainting myself. My first disclosure is that I was paid for to come and speak about this topic by CC Pharmaceuticals, who have this product which is displayed here. In your practices, I'm sure each and every one of you has received that call. Daktari, it has refused. Okay? I remember one of the patients I was looking after who called me at 2 a.m. Daktari, it has refused. Imagine the courage of picking the phone, the distress he had, and the courage of picking the phone at 2 a.m. to make that call and say, Daktari, it has refused. That is how bad erectile dysfunction is in our society. Unfortunately for some of us, or fortunately, or whichever way for some of us, by the time he's calling, maybe yours has just refused also, and you're still trying to figure out what you want to do. So, you start relating with his problem. So, we'll start with a clinical case scenario, one which I don't see who I looked after this patient with, but Mr. One-Term, Two-Term is a 70-year-old male, 112 kgs. I don't see anybody here near 80. He had recently had, or he had had knee surgery 10 years earlier, and he was walking with a crutch. He was in mild tachypnea. I don't know whether that's the one you call respiratory distress, but from a urologist's eye, I could see he was breathing very fast. Then along the way, I learned that he had been on treatment for pulmonary edema. He had well-controlled hypertension. He was diabetic. The previous speaker was talking about hemoglobin HB1C. Wametoa A, or it is silent. Allow me to use the old one, hemoglobin A1C of 13.5%, and his fasting was 18. At that time, his IPSS score was 30. out of 35, which is very bad. He was just 5 from being worst, so basically he wasn't being well. At that time, the question you ask yourself, if you are looking after this particular person, would you do a double IEF score, which is the best validated questionnaire we use for assessing erectile dysfunction. Because the rule, Dr. Ngogi will say, if you see a diabetic, check for ED. And I'm here today to emphasize that if you see a diabetic, check for ED. But looking at 1 term, 2 term at this point in time, are you going to be looking for ED? Maybe not, and indeed I did not look for ED in this man. I decided to take care of his urinary symptoms, see how to save his kidneys, and then we think about this erection later on. So the objectives of this talk, I was told, is that by the end of the day, you need to understand, or we have an idea of the epidemiology of erectile dysfunction globally, and indeed in patients who are suffering diabetes mellitus, to explain or to have an understanding of the pathophysiology linking diabetes and ED, recognize ED as a cardiovascular and metabolic marker. This one I will spoil if I talk about it. The previous speaker has injected me with a heavy dose of knowledge on the cardiovascular factors associated with diabetes and erectile dysfunction. And then we'll review some of the treatments that we have locally and whatever else is available elsewhere. And at the end of the day, appreciate how successful treatment of ED improves diabetes management and overall health. If nothing else, if you don't want to take home anything else, just the last point. So the definition of ED, of course, is inability to achieve or maintain an erection sufficient for satisfactory sexual performance. If you look at how Professor Gola defined it, he added vaginal intercourse. So this one is an international one. Why does diabetes, or why does ED matter? Remember the call I received at 2 a.m. For a surgeon, maybe you just go to sleep at 12:30, then, or 1. Then the call disrupts your sleep. Then after that, you start thinking about your own problems. It is more than a quality of life issue. It in fact impacts self-esteem, causes a lot of depression and anxiety, and we have a lot of relationship difficulties when there is ED. Yesterday, a young man around 34 years old walks into my office. He has a varicocele, he has a septic ankle, and he has a chronic DVT on treatment. So when I looked at him, I told him, this septic ankle of yours is an emergency. And he said, yeah, actually I need it treated. But he had come with his wife. And the wife said, Daktari, ata in emergency. So we negotiated for a few minutes what we need to sort out, because the wife was like, no, you sort him out there also, because I have suffered for long. So you can see, leads to a lot of relationship difficulties. So when they went home, I don't know what discussion they had. Dr. Ngunga talked about cardiovascular disease, but we also note that ED may be the first manifestation of systemic endothelial dysfunction. Commonest causes of ED, of course, is psychogenic. Probably you have had a bad day, or probably he or she annoyed you, or probably your pocket is not as good as you want it to be. You're thinking about the 5th floor of a 4th floor building that is approved, but you want to put a 5th one, and many others. But of course, here today, we are focusing more on the organic causes, diabetes being one of them. And where we sit, we notice that diabetes, the disease, diabetes, the complications, and diabetes, the treatment, all cause ED. Through neuropathy, vasculopathy, and in patients who have neuropathy, we like using pregabalin. I think that's what is prescribed, isn't it? Is it pregabalin? And pregabalin is a major contributor to erectile dysfunction. The burden of erectile dysfunction in the world is large. I don't want to look at anybody who's older than me, but ED increases with age. So the younger you are, and for those who are young, use it well, because one day you might not be able to use it that way. The estimated prevalence of ED among age groups is around 52%, ranging from mild or minimal ED to complete or severe ED. It is estimated around 322 million of us, Dr. Gaffner, us, 322 million of us worldwide have ED. But also, there is significant underreporting, because when you see a patient or you see a couple, he may not be worried about doing it. But he has the problem, but because he's not concerned about it, then he doesn't talk about it. Locally, we have came across 2 papers on erectile dysfunction, the prevalence, and this one by urologists also sometimes publish. Somebody called Dr. Onyango Lodge. They looked at erectile dysfunction in young men in Nairobi County, and it was a community-based study. The population was 18 to 35 years of age, and they found a prevalence of around 10.4%. You can imagine an 18-year-old is complaining about ED, and the associations they found were depression, anxiety, and diabetes mellitus. In the cohort, there was only one person with diabetes mellitus, and he had severe ED. So 100% for this particular study. Another study done by Professor Ogola and his team looked at the, erectile dysfunction in hypertensive people, and they found a prevalence of 94.5%, with 70% reporting mild and only 9% reporting severe ED. This slide is deliberate because this is a study done in 2014 in Muhimbili University, Tanzania, published in the Pan-African Medical Journal. You can see it's an old one. So what did they find? They found a prevalence of around 55%, and these are patients who are going to the diabetic clinic in Muhimbili. They looked at 312 patients sampled, an age of 51, a mean age of around 51.3. The range of the patients was 45 to 60 years of age. 80% of the patients had type 1 diabetes, the others type 2. I don't remember which one was 1, which one was 2. I only remember kulikuwa ya shindano na kulikuwa ya dawa. All right? And in this particular cohort, the prevalence of ED was 55%, with 28% having severe, only 13 having mild, and 14 having moderate. When I looked at this data, I tried to mine, and I realized the Kenya Diabetic Study Group is just the same as the Kenya Association of Urological Surgeons. We have not published any paper on diabetes and ED. Where is it? It's not visible. There is a lady there who presented in our conference in February. I see her there. I really looked for it. I did not see it. So how come we are not visible in that space? Muhimbili, 2014, they were visible, right? Cows, Kenya Diabetic Society, we are not visible. So as the vice chair of the Kenya Association of Urological Surgeons, I want to go and whisper to the one who sent me here to speak today and paid my bus fare, that they need to give us a little grant so that we can do something about ED and diabetes. okay? Because being the leading economy in East Africa, it is a shame that we are not that visible in our science. So diabetes and ED is the perfect storm. Why? As mentioned earlier, it's one of the diabetes is one of the strongest risk factors for erectile dysfunction. And men with diabetes mellitus are approximately 3 times more likely to develop ED, and they will develop it much earlier than their counterparts who do not have diabetes. They will have a more severe form of disease, and they will respond less robustly to medical treatment. And indeed, they have a higher rate of treatment-resistant erectile dysfunction. Endothelial dysfunction has been talked about earlier by the previous speakers, but suffice it to say that the way diabetes causes it is through multiple mechanisms. I would like to remind you that erection is a blood flow matter. As long as the blood doesn't flow well, there'll be no erection. As long as, and then also, erection is a matter of stimulation. For as long as he is not stimulated, then blood will not flow. All that is affected by diabetes through the nerves, through reduced nitric oxide production, through endothelial dysfunction, and then the cavernosal smooth muscle, which is supposed to engorge, or which is supposed to relax so that you have the engorgement of the sinusoids, does not happen. And then when I was reading like you guys read, Dr. Gaman, my classmate, reads, I think, 10 times more than I do. But anyway, it's all right. So we have also noted, or at least we have read, that there is a higher incidence or prevalence of hypogonadism in diabetics. But then also we have a high psychological burden in these particular people. This has been talked about a lot. Hypogonadism has been spoken about. HB1C, wacha nitoe A. Poor glycemic control is associated with an increased prevalence of ED and indeed a worse erectile function and reduced treatment response. That has been talked about. So, the psychological impact. Men with ED have higher rates of depression, have higher rates of anxiety, have more relationship distress, have reduced self-confidence. And then we are going to have a vicious cycle. Stress or anxiety, one of the enemies of erection is anxiety. Another enemy of erection is stress. So for the ladies here, you see they say, njia ya roho kwa mwanaume ni nani? Ni chakula. Hiyo chakula ni ya roho, ya tumbo, ya kichwa. The truth is, toa stress kwa jama yako, okay? Okay? If you remove stress from your guy, he's likely to get aroused faster, better, and longer than if you have stressed him. Okay? That is a summary of the psychological burden. Interesting that sometimes, or in many scenarios, ED has been the first clinical manifestation of diabetes or hypertension. Somebody is brought, afanye kazi vizuri, and then we also usually check vital signs in our clinics. So, because the person has been brought in for ED, then it gives us an opportunity to screen for diabetes, to screen for hyperlipidemia, and advise patients on lifestyle modification. So in our country, the way we were taught to assess patients for whatever medical condition was a history, a medical examination, very important, a drug history, and assess the person's psychosocial status. Yesterday, in one of our CMEs, we were told doctors have a burnout of around 60 to 70%, which impacts on your psychosocial status. So sometimes we are not patient enough to evaluate the patient's psychosocial status, but let us do that going forward. And then, of course, physical examination. Remember, Mr. One Term, Two Term is 112 kg. If you don't notice that, then you may not be able to look after that patient well. Always examine the external genitalia. Maybe it is going to be abnormal. And important for us, the validated questionnaires. We use the IIEF score to evaluate the patient and also to monitor response to treatment. I am already preaching to the converted, but let me just preach. The hemoglobin A1C, we'll look for it, we'll check the fasting sugar. There is a presenter who talked about big things. That's what we have not come across, but anyway, we'll send them to you so that you look for those things. Two presentations away. We always check the morning testosterone, that is between 7 and 10 o'clock, because we know that the failure to respond to the PD5 inhibitor sometimes is because of hypogonadism. And indeed, in one slide I'd shown earlier, I mentioned hypogonadism as being more prevalent in persons with diabetes as opposed to those without diabetes. Now, Doppler studies. In Nairobi, there was only one person who was doing, one person, then two, now three. And one of the reasons why these Doppler studies were not done is because the medications to induce an erection, an instant erection, were not very easy to find. And those who were bringing those medications, I don't know how they were importing them, because one time when we wanted to do a study, it took us 2 years to try and establish how to import these medications. And indeed, following my frustrations, the guys who paid my transport came up and imported their own. They'll tell you about it in their stands. So the IIEF score looks at the erectile function, orgasmic function, and the sexual desire. Important about erectile function is that one will be the ED itself you are looking for. But when you look at the sexual desire part, you are actually going to be looking at the hormonal part. So in hypogonadic individuals, the sexual desire part is going to be low. And then, of course, the intercourse satisfaction will point at the person's psychological status. When treating ED, we need to aim to integrate treatment into a sexual relationship. It is useless to give somebody a PD5 inhibitor and he has nowhere to go and use, okay? He has to have somewhere to go and use whatever he's looking for, isn't it? Okay? So the most important person in all this multidisciplinary team is the spouse. If she says, wachana na huyu mzee anatafuta vitu yenye haina maana, what are you going to do? Okay? But of course, important persons in this multidisciplinary team includes you, the endocrinologist, we, the urologists, there's a cardiologist who has just spoken. We have mental health professional, and in some jurisdictions, the primary care physician, if that is how the referral pattern is. Thank you for modifying your lifestyles a few minutes ago, but the first line treatment for ED is actually lifestyle modification. I asked Mr. One Term, Two Term to lose weight. After 9 months, he had lost half a kg. But I encouraged him, and I told him it is better than nothing. Never mind that the first time he came into my office, he had a jacket. The second time, he didn't have a jacket. Okay? We preach about exercise, smoking cessation, moderate our alcohol intake, and improve our sleep. And then, of course, we look at the kind of medications we have. In our country, we have a lot of sildenafils, a broad range of them, and tadalafils as well. Urologists like using tadalafil, especially the 5 milligram daily dose, as opposed to the 10, 20 milligram on-demand dosing. We try to play it safe, or maybe because we don't want to send the patient to Dr. Gunga, we want the patient to stay with us. So we don't want to do a cardiovascular risk assessment and increase the dose, because we are scared you might stay with the patient and I miss my next consultation fee. I don't know. But the response rates in persons with DM are lower than those in non-diabetics. Then most patients still get benefit, and the success rate is around 55 to 70%. The short-acting PD5 inhibitors have been shown to decrease HbA1c. Okay? So basically, I think that means it improves diabetic control, isn't it? We also know that testosterone replacement therapy, especially in hypogonadal men with type 2 diabetes, improve insulin sensitivity, improve or fasting glucose, the HbA1c, improve lipid profile, and improves the blood pressure. Outside of the medications, we have injections. Prostadil plus or minus paparavin or phentolamine are used to induce an instant erection. So these are injected into intracavernosally, or in other jurisdictions, there is an intraurethral instillation. The recommendation is that you have to administer these first two medicines in your office before sending them home. Okay? How practical that is? Okay, then we have vacuum devices. We don't have them in our country. And then right now in our country, we also have penile prosthesis for those who have refractory ED. The prosthesis itself costs around 1 million shillings. Okay, so you can imagine the ones we have locally in our country now. There are other treatments that are available. We have low-intensity extracorporeal shortwave therapy. This is approved by the EAU, but not yet by the AUA. It is said to improve revascularization. There are some people in our country who are injecting platelet-rich plasma in what they are calling intracavernosal stem cell therapy. Worldwide, this is investigational. So don't be in a hurry to send your patients for these injections. I know there is 1 or 2 people doing that in Nairobi. So the question is, can treating ED improve diabetes outcomes? Yes, that's the end of this slide. So our take-home message, therefore, is that ED is a common but underdiagnosed condition. Diabetes is a strong risk factor. It may precede what Dr. Ngunga said. Every man with ED deserves a cardiovascular assessment. So if Dr. Ngunga, if the consultations don't come, then you know we are doing wrong. Effective treatment can improve overall patient engagement and diabetes self-management. So treating ED is not just about sex. It is about vascular health, mental health, relationship health, diabetes outcomes, overall quality of life. And don't forget, an erection may be the symptom that saves a life. So erection is important. I would like to thank everybody. I'd like to thank everybody who has been able to listen to me, and to thank my sponsor, CC Pharmaceuticals, for asking me to come and talk in front of this very intelligent and very well individuals. Thank you very much.
Thank you, Dr. Ikol. I'll just ask you to remain on the podium. Thank you. So I want to invite the other speakers, Dr. Ombui and Dr. Ngunga, to come. We'll have a question and answer session that will be conducted by Dr. Rilwan. So if you've written any questions, you can just put up your hands and the usher will pick them. If you have a question to ask, you can also raise your hand.
Dr. Ridwan, can I go on?
Yes, Bundi, go ahead.
Thank you. My name is Dr. Bundi. I'm a neurologist. The first one is a comment. Thank you, Dr. Ikul, for stating that we need to have our evidence out there. I'm the managing editor of the JOCAP, the Journal of the Kenya Association of Physicians. So if you have any study on ED, send it to me, we shall publish, and we shall make sure our data is out there. The next one is a question. The use of testosterone for these patients with hypogonadism, how long do you use it? And what is the risk of prostate cancer? That is for Dr. Ikul. Thank you very much.
Okay, thank you very much. You are not the only one who baptizes me Ilkul, but mine is Ikol, I-K-O-L. 4 sweet letters. Okay? The other one, there is an Ilkul, I-L-K-U-L. Even the hospital is confused. The only thing they don't confuse is the checks. Okay? So, we will send, we also have Kenya Journal of Urology, so we can collaborate. On the use of testosterone, testosterone replacement therapy is interesting. We have to look at the rules as to how you want to administer testosterone. Right now in our country, for the longest, we have had the injectable form, but we now have the gel form. The guys who sent me here have one, a gel form of testosterone. There's a competitor of theirs who also have a gel form of testosterone. But however, the rules have to be clear. Do you want to boost the patient's testosterone level by exogenous testosterone or by stimulating the physiological pathway that produces testosterone? If you have a man who wishes to start children, then you want to stimulate the physiological production, which will be by giving HCG injections so that at the end of the day, it doesn't kill spermatogenesis, because it is known that exogenous testosterone reduces the intratesticular testosterone and therefore negatively impacts or imparts spermatogenesis. So for those men who want to start children, avoid or don't use exogenous testosterone. Duration is for how long, or what was the cause? If somebody has gonadal failure, then he'll never recover from it. So that person is going to be on testosterone replacement for life, or until such a time there is a risk or established prostate cancer. Because there is insufficient evidence on whether exogenous testosterone is safe for individuals who are on prostate cancer treatment. And indeed, for somebody who has untreated prostate cancer is a contraindication. And for somebody who has treated prostate cancer, give it with caution after remission for a whole year. So those cautions on use of testosterone in men are there. Thank you.
And maybe before we prescribe the testosterone, because we don't a lot of times do it routinely for our patients with diabetes, and we know we have the concept of now male obesity, secondary hypogonadism. And The question is, when should we routinely do testosterone for our patients who are obese, diabetes? Because it's not also, it's a quite, for the common one, and it's not a cheap test to do.
Yeah, that's a good question. In urology, we try and forget about the cost. Okay? Because we try and say, okay, this is what you need. I can promise you, the cost of not having an erection is very, 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 very high. It is much cheaper to look for that erection by doing serum testosterone between 7 to 10 than move around swallowing PD5 inhibitors for a whole year and you don't have response. There's one slide I pulled out because of just I didn't want you guys to go to sleep. But it shows that they looked at a cohort of persons on PD5 inhibitors alone and those on PD5 inhibitors plus testosterone. And they found the response to the PD5 inhibitors was better on those patients who had received testosterone replacement therapy. So don't shy away, just look for it. If you are scared of looking for it, send them to us. Thank you.
Any more questions?
Thank you very much. My name is Dr. Witty. So, Ecole, just comment on the myth on penis captivus, because this seems to be increasing, and I wonder what you expect the doctors around here to do when they are called in to intervene. Penis captivus.
I may have to Google this one, but you can describe.
Yeah. This is when male and female get together and then they get stuck.
Okay. That one, we were taught that that one was caused by the female, not the man. So, because in our course of studies, we were taught that that one is vaginismus. Now you must remember that in our jurisdiction, female genitalia is looked after by the gynecologist. So I'm not competent to answer that question, unfortunately.
Okay, so I think the next question, Wairagu, can we please, the cardiologist is here. I think the heart is also a very important topic.
Thank you.
My name is Dr. Anne Wairagu. I want to appreciate Dr. James Ecole for taking us through that. In the afternoon, I'll be presenting about the AROS study. But for this, my question is to Ombui. You talked about the point of care testing. I don't know if you've come across people who go to some tents which are set in town, and they come and they have done a full body analysis. And they bring those results and they are printed, and sometimes I don't know what to do about it. What are those standardized point of cares, and what's their role in our setting?
Dr. Wairagu, let me be clear. In Nairobi, you're only poor if you choose to be poor. There are people who have made tech to be a point for scamming patients. They get this technology from China and I don't know where you just put your hands inside and it detects if you have some form of cancer, some form of clotting issue, diabetes, and all those sorts of things. I always tend to say, if you are not sure of a diagnostics, and you see this thing purely, most of the time actually affects patients with NCDs. Because patients with NCDs are looking for a cure. And we don't tend to give them the cure. We tend to manage them and to be stable in the conditions that they are being managed in. If you go to somewhere and they tell you, if you put your hand in this thing, it can give you a diagnosis, and remember, it doesn't end there. Once they are given a diagnosis, they are told now, this bottle is 80,000 shillings, and if you take it for 5 days, your diabetes will be cured. And they come to you 3 months later with overt, suboptimally managed diabetes. So we know these things are not true. But because there is a gap, especially in information and in education, from, the public health sector has the preventive and there's also the curative pathway. I always tend to think that the preventive pathway is what we've not optimized. Education is not something that we've done well for our patients, and they tend to go and get answers elsewhere. So, Dr. Irogu, that is a lie. I don't believe in those things. It's next to Chawi, so no.
I think we'll finish with that one question.
Good afternoon. I am Dr. Kumari from St. Luke's Hospital, Eldoret Hospital. My question also on more or like the same to Dr. Omboi regarding the quality control. Especially, we are here as a Kenya Diabetic Study Group. We are more concerned about HbA1c, point of care, the same problem like what doctor has expressed. Every lab will give in point of care. In my own setup also, I have seen patients, there is discrepancy in HbA1c levels when we use the point of care machine. And the guidelines says that national NGSP, HbA1c must be in line with the NGSP, National Glycohemoglobin Standardization Program. So do we have any lab in our country to work with? Because there is, must be a uniformity across different labs. Thank you.
To answer you that question, one, we must be reminded that HbA1c is influenced by certain parameters. It's not one of the perfect tests, but when used correctly, it will give you good directions on how to use it. Remember, anything that affects the red blood cell can affect the interpretation of the HbA1c that you have in front of you. But the issue of standardization of kits, diagnostics, is beyond me. What I know is they have set parameters and set standardizations that have been put forward, and you can see them. There are ISO certifications, there are, I don't know what other things that are there. You need to know where you are taking your sample for evaluation. You have to be sure that it's a place that is standardized, that there's quality checks that are being done. I'm not here to market any particular lab, but I'm sure they can speak for themselves. In good hospitals, you will definitely find good standardized labs that have external checks as quality assessment for the kits and the tests that they do. And I know we are facing these problems of, we are mushrooming, there are these mushrooming labs elsewhere, which are using these point of care testing kits that maybe have not been standardized. It's upon us as healthcare providers to check and ensure where you are testing your samples is some place where you can actually verify your results. I hope I've answered your question. And I'm glad I'm getting more questions than the urologist.
Yeah, I think we have some labs in the stalls. You could probably seek further information. I think with that, we break for lunch. We come back at 2. Please, let's keep time, 2. You'll get your vouchers there. And as you feed yourself, please check how much adiposity you're accumulating.
You're soft-spoken. So Ajua, at the end of this presentation, you'll take a challenge with Beatrice. Okay? So Dr. Beatrice, karibu, and take us through the first topic.
Thank you so much, Dr. Matiko. So good afternoon. I know we've had very heavy talks for the past 2 days. They've been very scientific and lots of studies. But today we just want to highlight what is practical when we are talking about managing our elderly patients so that we can put all the science and now basically adapt it to the patients we're going to meet. So the topic is diabetes in the twilight years, and the focus here is on type 2 diabetes, We'll have a session after this for management of type 1 diabetes at the various stages of life. There are no disclosures for this presentation. So if we are discussing the elderly, I think it's important to define who the elderly is. And WHO has defined the elderly chronologically. As you can see there, there's a classification like young, old. Okay, so young, old starts from the age of 60 up to 74 years. Most of these people are in the peri-retirement phase, also doing various things. Some might be having older families and sort of, going into their enjoyment of retirement. Others might have started new families, so they are still having young children and still have, many things in terms of their day-to-day living. Then the other more practical classification is the oldest old, or patients who are advanced in age, so they're above 85 years. Majority of them have some form of functional mobility issues. And you need to look at what is the time frame to benefit. And here we're looking at if the life expectancy of your patient is likely going to be longer than the duration of some of these clinical trials, then the patient is likely going to benefit. Another strategy would probably be to look at, again, time to benefit can also be looked at in terms of how long do statins take to actually start giving the benefit of primary prevention. And a meta-analysis by a gentleman called German and his colleagues looked at this particular cohort, although it was still patients between 50 and 75. And the evidence was that at least the patient would need to take the medication for about 2.5 years before you start seeing the benefit of the statins. So if the life expectancy of your patient is likely going to be longer than that, then maybe you can justify use of the statins if they're tolerated. Then comes this group who already have multiple comorbidities, but they have some level of cognitive impairment. This group they are quite heterogeneous. And it's important now to look at many other things. Which kind of comorbidities do they have? What is the risk to benefit of medications that you want them to get? And what is their preference? I know quite a number of elderly patients do not like using insulin of treatment, and especially when it's multiple injections. So you will have to negotiate and see what is likely going to make them more comfortable. So you can see there, their targets for HbA1c are a bit less stringent, about 8. It's still justifiable to try and achieve a good blood pressure control in the elderly patients. Try to achieve at least a blood pressure of 130/80. They still benefit. You can see their levels for pre- and postprandial sugars are a bit lax as compared to the previous group. Again, there's benefit of statins here. But the last group is referring to very complex patients who have multiple comorbidities, severe cognitive impairment. Their life expectancy is quite limited. So here, your focus is mostly on symptom management. The blood pressure control is not very stringent, about 140/90. You can see even their control for pre- and postprandial blood glucose is not very stringent. If it's statins, you really have to sit down and weigh, is this patient likely to benefit from that medication? So lifestyle management is still important, even in the elderly group. A lot of emphasis is supposed to be made, especially on protein intake, because we've mentioned that quite a number of them lose their lean body mass, and they require at least a protein intake of 0.8 grams per kg body weight per day, and quite a number of them are undernourished. So let that conversation with the nutritionist happen. Then they get a tailored nutritional consultation that's likely going to help them so that they don't end up developing sarcopenia. Exercise is still a valuable part of their treatment that they need to and we encourage both aerobic, weight-bearing, resistance training so that the patients maintain their lean body mass. Then if your patient is overweight or obese, then we also still weight loss of about 5 to 7%, and benefits loss in this population. So when it comes to pharmacotherapy, because we meet these patients and they are quite heterogeneous. So we have elderly patients who have had long-standing type 2 diabetes over time with target organ damage or microvascular complications. There are still some who will probably have been undiagnosed. So by the time we are seeing them, they already have target organ damage, and that's the time we're diagnosing them with diabetes. But there are patients who are now newly diagnosed, no evidence of target organ damage. So as much as possible, our priority should be medications that have low risk for hypoglycemia. And if we meet the ones who have already been long-standing diabetes and they have been on some medications like sulfonylureas, you want to see whether you can de-intensify their treatment and put them on medications which have a lower hypoglycemic risk. Then if they are moving from the group of having, for example, no cognitive impairment, they get a stroke, now they are in severe cognitive impairment with dementia, with multiple organ dysfunction, you really want to de-intensify again the medication based on the risk versus benefit. And finally, in patients who already have atherosclerotic cardiovascular disease, heart failure, CKD, then try to put in the medications that have proven benefit in this category. So SGLT2 and GLP-1s can be quite useful. This is a busy slide, I know. It talks about insulin. So if you have a patient who was already on multiple daily injections, so they were using, for example, a basal bolus, and you already have evidence of hypoglycemia, severe hypoglycemia, how can you go about de-escalating the treatment? So if the patient was already on a basal bolus, then the basal insulin injection can be switched from a night injection to a morning injection because you want to minimize the risk of nocturnal hypoglycemia. So the other thing about the prandial insulins, so the prandial insulins, again, if they were using high doses of more than 10 units, for example, preprandial, that dose can be halved to about 50% as you monitor. And the ones who are using less than 10 units, you can consider changing to an oral medication that has less risk of hypoglycemia. So as you're adding the oral medication, also consider the GFR. Remember, the GFR is going to be significantly reduced even if their creatinine looks essentially normal, so that you're giving medications that are also not going to give us further renal compromise. So this slide tries to highlight how do we assess so that we can categorize our patients who are elderly. So if a patient has had a medical event, so a medical event can classify as an admission because of heart failure or an acute infection or an atherosclerotic cardiovascular event, then that might mean that they may be classified in a different group from where they were before. Then these patients can also have life-altering events. Remember, the medical events can also be life-altering events, though some life-altering events may not necessarily be medical events. Like, for example, the death of a spouse, and the spouse was probably the primary caregiver. That might make you need to review your treatment plans. If you start seeing changes in their cognitive function, so there is the progressive dementia, or you're seeing adverse effects of medication, for example, hypoglycemia, severe edema, especially when they are on calcium channel blockers and they also have significant venous insufficiency. So when you start seeing certain changes, then that might also want you to investigate, find out whether there's something about our medication that might require to be adjusted. We talked about the signs of unrecognized hypoglycemia. Remember, these patients sometimes still come with symptoms of severe hypoglycemia. They can still come with osmotic symptoms, especially if they have an infection, they've had an atherosclerotic cardiovascular event that is silent, like an MI, so it's important to evaluate for those. So as we evaluate, then we also re-evaluate our glycemic goals, and we discuss this with the primary caregivers. So if the patient initially was the one doing their injections, now they've had a stroke, they have significant cognitive impairment, somebody else has to do it, our glycemic targets have changed, and those adjustments require that they are communicated appropriately. So we are required to de-intensify and simplify treatment regimens as much as possible so that we optimize safety. We also minimize polypharmacy by using combination treatments, as long as the combinations are taking into account other things like the GFR of the patient. Then when we give this new prescription and make sure now it is understood by the primary caregivers, then we need to reassess, and probably within 2 weeks. So the reassessment can be either after using CGM, or you've asked the caregiver to be doing the random and the fasting blood sugar checks so that you can see whether you are now in line with your new treatment goals. Finally, we want to talk about end-of-life care. So remember, in the journey, at some point, our patient is going to exit. And here we want to prioritize overall comfort. Diabetes is associated with an increased risk of cancer and other end-organ, end-stage organ failure, whether it is heart failure, kidney disease. Some patients do not want to be put on dialysis. So you need to prioritize comfort, prevent distressing symptoms like pain. Remember, hypoglycemia needs to be treated or to be managed, because if you don't manage the hypoglycemia, this can likely be a terminal event. It can actually be the one that causes the patient to pass on. We are still supposed to consider management of severe hypoglycemia as part of the goals of management of palliative patients. So here we are considering mostly overall comfort, what is the quality of life of your patient, and dignity. So the patient has a right to refuse multiple injections, multiple checks of sugar. They might not want to have many tests. In fact, at end of life, there's really not much role of HbA1c monitoring. We've mentioned why it's important to prevent hypoglycemia, because, as I've said, that can be a terminal event. But if patients are in terminal delirium, those are now the final hours before death, then medication for diabetes can be discontinued. I think my final statement is that, so taking care of elderly patients can be quite tedious, okay? You will repeat yourself many times, okay? But it can be very fulfilling, okay? Just seeing the impact that you can make in terms of their care, I think it's worth all the effort. And I think now the priority should be not just adding days into their lives, but adding life into the years that they have left. Thank you for your attention.
Asante, Dr. Beatrice. A round of applause again to Dr. Beatrice. She has donated to us 6 minutes, having started 10 minutes late. And now we are moving to the second session, and I want to welcome the moderator of the session, Dr. Dara Patel, who is a physician endocrinologist practicing in Nairobi, to take us through this session. Karibu.
Thank you, Dr. Hiro. So we are here now going to have a multidisciplinary team. They are mainly here with Dr. Joyce Mbogo, is a pediatric endocrinologist. I think majority of us know her, and she practices in Nairobi, I think in most major hospitals, University of Nairobi. She's trained many of us. Then we have Monica Saulo, who is a diabetic educator, both for children and adults, and she works at the Aga Khan University Hospital. And last but not the least, and one of the most important members of an MDT in diabetes is Valentine Katambi, who is a clinical psychologist working in Nairobi. Welcome, Dr. Aris.
Thank you very much for the introduction. So welcome to the MDT. We are not complete because we don't have our nutritionist. So please bear with us, because we'll be talking and just passing the microphone from one person to another. But it is important to understand that when you're working as an MDD, then you need to keep communicating with each other, because that's the only way you're going to get better care. So it is a management of type 1 diabetes holistically from every stage of life. And as you can see, we're starting with, yes, all right. This is going to be our outline, okay? So Why does the lifespan length matter? It's because we know that we're diagnosing children with type 1 diabetes all the way from 1 year, actually, towards even the 25 years of age. So it is important wherever you meet them, you walk with them at the stage that they are. What do we know so far about type 1? We know that at least we know that we have approximately 1.2 children with type 1 diabetes. And we also do know that every year, around 2 to 3% are newly diagnosed. Unfortunately, in our setting, that is not happening. Why? It's because we are misdiagnosing them, and so we are losing them. So we're here also to tell you, please, if you see polyuria, polydipsia, polyphagia, just check a blood sugar in any child to make sure we can be able to diagnose that. All right? Good. So we also know that relatively, children who have type 1 diabetes are also at risk of getting mental health issues just because of the condition in which they actually have, right? Diabetes to stress is very common. And unfortunately, for many of us, we only think about the child. But guess what? The healthcare provider can also get diabetes to stress. And that will affect the outcome as they take care of the child who has type 1. So we're here to tell you, walk with us. Now, if you look at this chart that is over here, that you see an infant all the way to an adolescent, you'll see we're asking you, walk with us as you go through our case. And you see that what matters at the stage that child is in at that particular point. Can I take an example of an adolescent? I can talk and talk and talk as a parent to an adolescent, but who do they listen to? Their peers. True or false? True. Number two, what they want to say, they want to differentiate you, the parent, from themselves because they want their own identity. So we want to walk with you as you walk through with this child so that you can be able to identify this child is at this stage. What is important to this child and who is important? Who do they listen to? So as you educate them and as you manage them, you also put those who are important in that group so that you can be able to get what you want to get from that. Okay? So we all have roles. Like I said, we're meant to be an MDT, but there's more here, right? The doctors give very easily. We prescribe insulin. We say take 2 units here, 3 units there. Very easy, right? Then we have our diabetic educator, the hard work. They have to teach. And they're teaching not only the child, but they're teaching the what? The parents on how to manage. Because diabetes does not live in the hospital. It's a lifelong illness. So you need to go there. Then we have to assess where they are. And that's where we need a what? A psychologist. And that's why we are actually here to take you through that. To help us out with that, we're going to meet NA. So NA is a 2-year-old male, and he's a real 2-year-old male, previously healthy, developed polyuria, polydipsia, and polyphagia for 2 weeks. Went to the hospital, was told you have type 1 diabetes. Went in, we're very quick. Parents were so shocked, concerned, HDU, treated them, DKA protocol, did excellent. But let me take a little bit closer to this child. Guess what? This is a new couple, just married, first child, right? So you're looking forward, maybe they want 7 children, first child, being told that they have what? Type 1 diabetes. In that whole family, they are the first grandchild. The parents are like, what? Type 1? No. That's not in our family. No one within our family has. So we're going to use NA all the way from 2 years to follow up. Now, I'm going back to my MDT. This child, I have done the easy part. I've put them on insulin. I've told them I'll check the blood sugar. So let's go, and you, as a diabetic educator and my psychologist, help me help this child.
So I come in as a diabetes educator. So who am I going to educate? It's the parents and the people who are taking care of this baby. This can be the relatives. Remember, most of our kids sometimes are taken care by the aunties, the uncle. So make sure the education covers people who come into contact or care for the baby. Now, the first thing is they need to understand what diabetes is. So you find the doctor has explained it, but I come in to repeat it and again because sometimes they are in denial. So before you go to other priority education, you need to see the approach. How do we approach it? One, how is their psychological status? Are they willing to learn? If they are not willing to learn, please postpone the session. Because sometimes you can come in, the mother sees me or sees the diabetes educator, they start crying.
that means they are not ready to learn. So they have to be seen by the psychologist first, so that they are able to go through the process of acceptance and grieving, where the psychologist will explain it more. Now, during the session, we are going to cover who am I teaching? The people who are taking care of the baby. When? That means the first contact, it can be either in the hospital, after admission, in the ward, or even at home, or even in school. What topics need to be covered? Like, most important ones are management of hypoglycemia. Remember, the age is between 0 to 3. This is the age where they are mostly at a higher risk of hypoglycemia. We need to teach them about management of hyperglycemia, blood sugar monitoring, and interpretations of the blood sugar reading. This is where now maybe the blood sugar ranges will be much wider. For example, it can be between 4.5 to 10, so that it reduces the risk of hypoglycemia. Injection site. This is where my body comes in. Is my body handsome? Yes. So, when I'm teaching the injection technique, this is the body that I will use for the 3-year-old to understand why the friend needs the injection, so that they feel they are not alone in this. But the best person to do the first injection through the guidance of a diabetes educator should be the mother, because that is the person the child trusts most. Now, when it comes to the meals, carbohydrates counting is still achievable, but now what happens is you have to maintain constant carbs for the meals, and you get what the mother has been giving the child, the meals at home. Don't come up with meals that are no longer, or they don't use it in their community. Lastly, we have to teach these parents and caregivers survival skills, like reducing the carbs amount so that they don't have to bolus for the meals. Teaching about hypoglycemia correction. For example, a child can get hypo and they are sleepy. Now that becomes a bit of a challenge, which would be a quicker way of helping the mother to sort it out.
Just like as doctors, as medics, what you look out for is physical milestones. In psychology, we also have psychosocial milestones that every human being goes through, right from when they're born all the way to when they transition or they pass away. And at every stage, there is a core relationship that matters, that helps the child or the person be able to successfully go through that process, okay? Why is this important? Because then you know who to talk to for what and at what point, okay? So from 0 to 3, Monica, Saulo just mentioned that the mom is the one who's supposed to give the first injection. Now, when a child is born between 0 to 1, the core relationship is the mother. Why? This child, that's the only person the child knows, because this child has been in utero, has had the mother's heartbeat, knows her voice, and so on and so forth. So that's how children tend to know who the mother is, right? However, for the father and the other caregivers to be able to come in, then that means that that means that they need to have started building that relationship before, okay? So at this point, what are we doing? Number one is going through the stages of grief, okay? Helping them understand what is going on, why they're feeling the way they are feeling, where they are at psychologically, and this is something we're going to do across every single stage, okay? Number two, children thrive on consistency, right? So if this child is able to know that my injections are going to come at this time, then that makes it easier for the child to go through the process at this stage. The other one is adherence counseling, which is now not done just to the child, but also to the parent, helping them understand why they need the medication, how they need to administer it, and additionally, why it's necessary for them to maintain the right amounts, the correct medication, and to make sure that they're not missing any doses.
All right, now from 2 years going to 4 years, has been taken care of by the family, has never been away from the mother, and that is very true for those 2 years, and has been thriving. So it is time to go to kindergarten. So the question comes in for us as they come into the clinic, how do we empower this child, parents, as they transition to the kindergarten? First rule is they come and tell me I want to go to the kindergarten. You know what I tell them? Go talk to who?
Now we are ready for school. So here comes. The parent has to choose a school. For those who are able to get a school with a school nurse, we are able to train. For those who do not have a school nurse, we are able to train the people who will come into contact with the child. That is, the teachers, especially the teacher who teaches that child, the assistant teacher. If there is a school nurse, that's okay. The principal or the head teacher of the school. Now, what we usually do is we teach the teachers on how to identify the signs of hypoglycemia, and we ensure that the child goes home with a hypo kit. So please ensure any patient of yours on a basal bolus should have at least a hypo kit wherever they go. Whenever having a session, use simple language. We avoid hypoglycemia. We say low blood sugars, identify the signs of low blood sugars. Now, at this age, some of them may not be able to identify what the signs of hypoglycemia is, but maybe they have been using a specific language like, "Mom, I feel sick. Mom, I feel tired." That is the same thing you communicate with the teachers if the child cannot express themselves. And then establish a care plan for this child, whereby the child has to go with the bolus insulin, a snack, any allergies or anything, activities on which particular day. This is the stage whereby a mother always calls. Why? In school, they are always at a higher risk of hypo, especially in activities. Hyper, the meals are well controlled, and sometimes teachers are even afraid of feeding them because of hyperglycemia.
Something else I forgot to mention is, just as they have at every stage, there is a key relationship, there is also a core need, all right? So 0 to 3 is, am I safe? I've just come into this different space inside mommy's womb. I was nice and comfortable, and there were all these things I'm seeing were not there. So now when we go to age 4 to 6, the key relationship still remains the parents, the caregivers, social surrounding, and school. Why social surrounding? Because this child has started going outside to play with others, okay? So they are being invited for birthday parties. And so as a parent, the need is to ensure that the ecosystem you've created around your child, socially, in terms of education, and within the house, extended family, they need to be empowered on how to train in regards to that. Number 2 is managing separation anxiety. As Saulo said, this is a point at which the mother keeps calling school, right? To make sure that everything is okay, that the child is doing well. So if this is not managed, then it can escalate and move from just separation anxiety to generalized anxiety disorder. Okay, we're also still looking at the stages of grief. Where is this parent at? and to some extent, where is also this child at psychologically, okay? And then coping techniques, how the parents, the caregivers, the environment around this child can find healthy coping skills for their psychosocial stressors that they have. As caregivers, the main role is to, 1, watch for stages of grief, 2, assess for diabetes distress. So this is usually done using a tool, a psychometric tool. And number 3 is assessing for fears. If you don't know what or where this child is at, or the family, then it becomes very difficult to explain or to know the how to go about it.
All right, moving on. Kindergarten, usually 10 in a class. You have 2 teachers, you have an assistant. So basically the child is really pampered. There are many healthcare, not caregivers within the class. Then you go to primary school. So primary school, what happens again in primary school? You're now from 10 to 15 in the class to what? If you're lucky, 30. If you're unlucky, well, 100. True or false? Right? So you're coming from a very small, very protected place to now the parent has to think, my child who still can't take care of themselves is going to a bigger class. Secondly, kindergarten, you play around, sandpit there, run around there. In primary school, you have a ball that can be made from a paper bag, and you're going to be out for lunchtime, and you're going to play, right? The days are longer, so that means a child is going to be longer in school, there are more activities, and there are more children. So the question comes in, how do we prepare our parents, our child right now, because the parent is not there, and the school to take care of this child who now has been 4 years or 7 years with diabetes? Again, it goes back again, you want to have those discussions with the diabetic educator. What kind of topics should you discuss, and how do you prepare this parent?
Now, you see, as a diabetes educator, stroke a coach, it's a continuous process. Our child now is between the age of 7 to 12. This is where now they look for privacy. Which place can they inject themselves, where, and they don't want people to know that they have diabetes. Now, this is where we get a lot of hyperglycemia, because they will say they didn't have time to inject, they didn't have a room to inject, so they decided, this time let me see if I'll be able to have normal sugars and after eating carbs. Now, NA will still continue with education about type 1, whereby in this management, we'll teach them how to calculate their use of correction factor, how to correct hypoglycemia, and about school trips and exercise. Remember, this is the age where they are trying to discover themselves. In one term, they're choosing swimming. The next term, they're choosing football. I believe parents who have kids, they experience the same thing. So different sport, each time they choose because they change their mind. So diabetes management in exercise is also important. Now, they will request frequent sleepovers. This is whereby parents have difficulties in cutting off the umbilical cord. The mother has always been on the driver's seat. I cannot let my child go sleep at a friend's place because of fear of hyperglycemia. Now, we still encourage the parents, but they are too rigid. So again, we will send them to the counselor for that. For the doctor, they will sit down and ask what happened, what caused your hypoglycemia on this particular day, as per your readings, any challenges in school, how can we manage? We tend to ask them for the solution instead of giving them answers. Remember, they are growing.
So you'll notice as we go stage by stage, we are carrying along the key relationships, okay? So just because 0 to 3 was the parents and the caregivers does not mean now when we go to the next stage, they come out of the space that, or the role that they play. So again, 7 to 12, this is where the peers come in. This is where you're trying to talk to your child and they're looking at you like they don't know what you're talking about, you're backward, you're shady, etc., etc., right? Now, It is important for parents to learn how to evolve with the child, okay, at every stage. Know what is the need for this child and how, as a parent, should you show up for this child. If that is done right, the parents become a sphere of influence and are seen as peers, because this child sees that this is my mom, this is my dad, I can talk to them about anything. So it's important to encourage the parents that we interact to ensure that they're evolving with the child at every stage, okay? The biggest problem at this stage is usually sharing of responsibility with other people, okay? Very similar to what we saw in the middle stage, yes, not actually the early stage, the from 4, yes. So same thing, fear of now, and you know, the letting go is not just on the child, it's not to the community, but the parent now trusting that the child can actually administer medication to themselves. That becomes a very, very tough thing for parents, and even for the children, the embarrassment, the fear of being seen as different or weird and all that, those things start coming up at this point, okay? And the thing you need to consistently check for, again, at what stage of grief are these people in? Bearing in mind that stages of grief are not linear, right? Today you could be in acceptance, tomorrow you're in depression, the next day you're bargaining, and etc. and etc. So it's important to consistently check that and also check for diabetes distress. The other thing to look out for is extreme sadness. This child, are they withdrawn or overly out there? Are they sleeping more or not sleeping at all? Are they feeding more or not feeding at all? Because a lot of times when we are screening for depression, we only see the low part, but it's the two extremes. If the symptoms are high, where it's hypersomnia, binge eating, and so on and so forth, you also look at the opposite side of it. So it's important to also check out for that, for both the child and the parent, okay? There's also the issue of balancing supervision and independence, because now this child feels that they're big enough to be able to take care of them, and this is where you see a lot of parental strife between children and their parents. Understand that if this stage is passed well, if this child attaches to the peers, to the school, to the neighbors, then they will have a very simple teenage period or adolescent period, okay? Because they're not now struggling to understand themselves and all that, but because they have people, a community that has been formed around them, a healthy community, then navigating adolescence and future stages becomes very easy.
You have heard, we are trying to build a community for this child. So the community started with who? The parent. Then now we talked about the community starting with the school, the teachers. And now we're building in the what? The peers. Because that community is what's going to empower this child. So please just have that. We're building in, and all of them, we are educating them so that we can support what? This child. And all of this, please remember, we need to keep assessing for diabetes distress, both now at the child and the parents. Because if you don't do that, you don't pick it up, then you're not going anywhere. So let's move on now, going to high school. What happens in high school? You're going to boarding school, right? And I'm going and they do many things, and I'm going to have to rush out. Puberty is happening. This child actually wants to not have anything to do with us, the parents, unfortunately. It is a very difficult part, but if you can just survive this part, I always say, parent, survive the parent. Encourage the child. Be there. Guess what? Once they get older, things go very well. So I'm going to ask the educator, because that's when everyone becomes a counselor. It's not just the psychologist, it's a doctor, it is the nutritionist, it is actually the diabetic educator. And you have to keep speaking to each other to know what's really bothering this adolescent. So let me just send back to my diabetic educator, who does, oh my God, they even go home to help me manage this.
As you heard, tsunami begins. Now, this child, remember at the age of 0 to 3, the parents were in control. Now, at this age, we want them to be in the control seat. The mother had a plan between 0 to 3, how to maintain, how to manage the sugars and the foods. Now, 13 to 18, They want to try out because of peers. They want to eat out. Now they want to take full control. So remember how I introduced myself. Educator, nurse, and a coach. In this stage, I become the judge because the teenagers will come and tell me what the parents have refused, and I have to listen to the parent what the child has refused to do. You see how it takes? Good. So this is where effects of puberty also affects the blood sugar. You have to teach them about their menstrual cycle, what happens with it, with the sugar, how to control it. And this is the age where also they are eating a lot. I believe those who have teenagers at home, you can buy a loaf of bread and it's still not enough. Now, this is a diabetic patient. The mother is limiting it and saying your sugars will go high. And this child is constantly having hunger. How to sort it out? You have to balance in between and introduce snacks that don't have carbs. They also want to try substance abuse, like alcohol. They are at a peer age. They will come and open up and say, Saulo, I went with my friends, I took 1 bottle. How do you handle it? Because if you tell the parents will end up beating the child or disagree, and the child will lose trust in you. So you find a way of how to tell them to take care of themselves, because soon they will be transitioning to adult clinic. And we don't want to give adult endocrinologists a lot of work, because right now they believe the patient is older and they know how to manage themselves. And this is where they need a lot of psychological support, a lot of encouragement, and this is done through peers, and also give them older people at least to work with them and share their experience about it.
So at this stage, the peers now become the center, the epicenter of this child's life, okay? And they're constantly seeking for acceptance, identity, privacy, and independence. On one hand, they want to be accepted by their peers. They want to be seen as part of the group, not like they are different or weird or anything like that. But on the flip side, they also want their privacy. This is a point where now children are able to decide, this is information I'm going to share, and this is information I'm not going to share. And the key thing at this point is to empower the child to at least have 1 or 2 friends, okay, who know the condition the child has. Number 2, know what signs to look out for. Number 3, what to do in the event of hypoglycemia, okay? So with that then, once you've created within the peer group, right, this also offers psychosocial support for the child, okay? They're not going through this thing alone, okay? There are people surrounding them who have been empowered by the child, chosen by the child. That's where the independence comes in. And also privacy, because this is not information they want to share with the whole world, okay? So again, at this point, what do we look out for? Still, including the children now and the peers in the diabetes management. Number 2 is adherence counseling. Now, remember the first time we did adherence counseling, it was with the parent, okay? Now, this child is probably taking total control of administering medication to themselves, okay? So if they are not well trained, if they are not empowered well enough to know what to do when, then that becomes a problem, okay? This is also the point where you start experiencing a lot of... Another thing to look at is, as Saulo said, at this point, they're experimenting with substances, okay? And if this child has depression, then we know risk-taking and eating disorders will start showing up at this point, okay? You might see levels of either binge eating, which is this child is growing, they need to eat more and all that. And if they have an oral fixation, it means they get soothed through the mouth. So food becomes now the thing that they used when they are stressed, okay? Or you also see instances of bulimia and anorexia. Again, because why? This child is choosing, they want to look a certain way, they want to be seen in a certain way within the community and amongst the peers. So you might find this child now, in fact, this is a point where hypoglycemia is seen at the highest, right? Purely because of risk-taking behavior and eating disorder. So the caregivers need to, and primarily that's the parents, learn how to let go gradually, okay? This child, I constantly say that 2-year-olds and teenagers are very similar. They both throw tantrums, and for the same reasons. Why? A 2-year-old thinks they're big enough to do stuff for themselves, right? They're able to walk and all that. Teenagers also are looking at themselves and probably, like now my son who is much taller than me and taller than the father, so he's feeling, what are you telling me? Why can't I go out? Why are you telling me not to eat this and not to eat that? Why are you denying me access to go outside for sleepovers and hanging out with my friends, okay? So it is important to empower the parents to learn how to start letting go, but in a responsible way, where yes, they're not being helicopter parents, but they're being what we call authoritarian. They're to offer both physical and psychological support. And then managing the fear of responsibility transfer, again, you'll see a lot of anxiety amongst the parents at this point.
Right, I think we have taken you through that, through all the stages. Looks a little bit complicated. All we're saying, let's work together. Always remember you have to look at the psychosocial part. Remember who is important for every part, what is important for that stage, okay? As much as possible. Remember, we all play a role. All of us who are here play a role in taking care of these children, adolescents, and young adults. So let's take up, because that's the only way we'll get a good outcome. And one thing that helps us to be able to have a good outcome is if we talk to each other. Because let me tell you the truth, if Saulo gets to find out there's conflict in the home, no matter what I do outside, and no matter how much insulin I give that child, guess what? The management and outcome is done. But sometimes they're all perfect in my office until they go somewhere else and they show the real colors. So by just having communication, a close loop within the healthcare providers, we're able to actually pick up things, deal with them at that stage, and then grow. Secondly, we as healthcare providers need to grow with our patients. Remember that 2-year-old? I wasn't talking that much to them. When they got to 7, I started involving them in these discussions. By the time they're teenagers, guess what? I talk only to them, and then the parent adds in. Now that has to be done intentionally throughout, and at the same time, emphasizing to the parent, I'm doing that for the benefit of the child, because it is their condition. Overall, let's work together so that we can get better outcomes. Thank you.
Sorry? Doc, just wait. We'll have the Q&A. Okay. I'll call Dr. Beatrice to come up for a Q&A. And anybody who has questions, you can raise your hand or pass the sheets if you have any. Thank you to our MDT team. That was a wonderful 18 years journey from a newborn up to 18 years. And now the adult physician and diabetologist has much less work to do because we have a fully prepared adult who knows how to manage and will probably teach us much more than we know. Any questions? For the sake of time, we'll have one and maybe one more question. Any burning?
Thank you very much, and I'm very happy to see that there's that lobby for working together. And I think it's important that we also work together, not just in the different specialities, but also even in the same specialty, because you might have you're a diabetes educator or you're a doctor, and the child probably prefers to speak to a man for the kind of issues they're going through, especially during the adolescent. But my question actually is, how do you share the data between the three of you? Because there are two things. One is privacy. Secondly is accuracy of the data. Because if you're, I mean, I'm asking it in a practical sense. Do you call up Saulo and tell her, hey, there's this child I'm sending you, and he's thinking of getting a girlfriend, and so.
Best way to do that right now, because of privacy, you can't write an email and stuff like that, is just to give them a call. In fact, if something happens, Saulo sees someone, she'll actually give me a call and tell me, hey, by the way, this is what I noticed with this child. So by the time they're coming back to see me, I already have that. I will go write in my notes that this was actually noted about this child, so that I can be able to pick it up at that particular point. When I feel there's something going on with this child that needs to see a psychologist, chances are they won't even show up on the day you send them. So I'll actually call, hey, listen, I've sent this person. I hope they show up, because you see, for psychology, they will not go until they feel they really need it, right? So at least if you have actually spoken to your counselor, to your psychologist, and told them, I have sent this person, and these are the reasons why I have sent this person. By the time they show up and they talk to them, they have an idea of why, and then they will loop back once they see them in terms of that, just because of the privacy issue. Anyone else would like to add?
So in psychology, because of the sensitivity of what happens in the therapy room, we usually have something called a consent agreement, which just ensures the patient or the client that your information is safe with me. And we go a step further to tell them, even in the event of incapacitation or death, we are still bound by law to keep our mouths shut, okay? However, we have a clause, and we even take them through it. We have a clause that says, however, in certain circumstances, then it is necessary for me as a therapist or for the doctor to refer you to somebody else, okay? And that is usually a discussion we have to have, and they will sign a consent form in regards to that. I don't know if that answers the question.
Any other question? Probably not. Thank you so much to our presenters. I think there's a question, Sama.
Hey, my name is Jen. I really liked the transition from the child to 18 years. I was growing with NA very well, but now my question comes at 18 years. So looking at the current Kenya, how it is, we have the CDIC that's supposed support children up to 25 years of age. And it makes sense because at 18 to 25, you're not very able to handle your finances, handle your medication and all that. And also, just some of them, even at 18, they are still in school. So my question comes, what are some of the transition mechanisms that are there? Because I feel like we lose a lot of kids in between 18, and some of them are not even sure who they're supposed to see. Or if you get someone, if you get a kid at that age, sometimes they ask you, should I see an adult doctor or a child doctor? So yeah, I would have loved to see more milestone after 18 years. Thank you.
Yes, so the role of transition clinics.
So I'll take it into steps. One, I think we have done very poorly in terms of transition from the pediatric side to the adult side. We're struggling with that. We actually have a working group that is working on that to see how we can transition, because there's a transition in public setting and there's a transition in private setting, where at least sometimes in a private setting, they're still covered under the parents' insurance, so it gets easier. However, also insurances also will determine who will see them at what particular point. So what can I say? For me, I've always felt that the person who is usually constant is actually the diabetic educator, because they're the ones who keep moving with them, unlike the healthcare providers. If possible, build that relationship also and offer them, at least by the time you know this is time to transition, of people who they can be able to see. I try and start having those conversations around 16, 17, tell them, by the way, you know, once you get an ID, it's difficult for me to have some conversations with you. So then you're offering them these options. And by the way, there's this doctor here, there's that doctor there. Would you want a male? Would you want a female? Would you consider just going to meet them for one visit? And then if you like them, then I can be able to transition you to them. It's not a perfect one. We're really hoping the working group will really help us and give us a better way to transition them, because it's transition for where the healthcare provider is transitioning and handing over the child. But there's also the financial aspect of it. Like you said, at least we have CDIC that is taking care of our children who are 25. What about all these other children who are not in our program? What happens to their insulin once they graduate? That becomes an issue that we have not been able to. However, guess what? The answers are here. So I'm going to put it back into the audience. What answers can you be able to give us? And if you're really interested in transition, I'd like Saumo to just raise the hand. Saumo, she's actually here. She's in the working group. I believe Rosie is also in the working group. Ruwal is also in the working group, because it is something that is really bugging us. Please join that working group, because we are trying to come up with solutions that cater for all of our children, adolescents, and young adults, so that at least then we can be able to start preparing them. We don't have answers. We're looking for them. Join that group so we can come up with solutions.
Thank you. Maybe Beatrice, of the 4 M's, if you had to choose one as the most important, of course they're all important, but if you had to pick one, which one would you pick in the twilight years?
I'd say what matters most to the patient.
I agree.
Pick that. Yeah.
Since there's no controversy, asante sana. So for those who see patients, a consultation that takes less than 3 minutes, sometimes we see patients in less than 3 minutes and they're out with a prescription. In twilight years, listen and actually attend to what matters most. So asante sana, another round of applause to our presenters. It's been wonderful and quite revealing. Asante sana. A photo. So I'm informed we need to have a photo. And I think to make it easy, Anne, you could just come so that we save on time. Come, Doc. I think Eric is not in, otherwise I would have seen him coming for the photo. Because he won't just let me have a photo with ladies and... All right. Thank you. So our next presenter, and I'm not going to allow her to go back, is one Anno Wairago. Anno Wairago, in past years, has been referring to herself as a village doctor. But I came to realize she loves urban centers more than the village. She's a consultant physician and endocrinologist, working with Kiambu County, specifically in Gatundu. She's also a member of Kdsg Executive Committee. So Anno Wairago and Arouse are synonymous. She aroused my interest to complete my MSc in diabetology, and I did it. Otherwise, without her consistent, reminders, probably I would have dropped off. But most of us, when we knew her, she used to arouse us, to go dance and, and dance to her drumming and all. So it seems Arouse and Anne will continue, being partners. So this afternoon, I have the pleasure of bringing her to you to take us through the Arouse study. And she's promised to cut 10 minutes from the initial given 30. Karibu Anne.
Thank you. This is my disclaimer. I don't take all the praise, because it's not my work alone. This study is by members of the Kdsg group, and some of them, they are here. So in this particular study, I want to honor one Dr. Boni Ale. Let me give you a brief of how we came with this study. When Kdsg was formed, I know Dr. Paul Ngugi is around there, we kept on postponing when we knew one of our mandates as a study group is to do research. So every year, every conference, we kept on saying we need to present data. We go conferences, we say there's paucity of data. People attend international meetings, they say there's paucity of data. Then we pause and we wondered why? What is our role? And we were honest with ourselves. The previous Kdsg president, Professor Nancy Konyeha, sat us down and asked, what's the problem? Why are you not moving forward? And we had an honest and we were vulnerable and we said, we don't know how to do research. Because most of us had done the IMED in the different university. I remember my experience. And we got scared of study, so it was not something that we were meant to do. And we had a consultation, and we invited Dr. Boni Ale. Boni Ale is in the house, you can say hi to the team. So Boni Ale had a program where he trained us, and the executive, around 20 of us, and he took us through a 3-month training, both a physical and an online training. The ECOM program, we even got certificates. And out of that, this Arose trial was pending somewhere, and he dusted it for us. And out of that, we were able to come up with up to more than 20 papers. So the first paper was by Rilwan Aden on female sexual dysfunction. And she actually presented last year in Vienna, Australia, during the ESD program. So the other members in this study, I have my friend, Dr. Kelly Florence, there's Saira Sokwala, there's Nicola Akech, there's also Dr. Boniale and Wakaba Nelly, among us others, which have not, but these are straight members from the Kdsg. So when you hear Rose study, this is not Wairagu, is a whole team. But it was a lead study for the male sexual dysfunction together with Kelly, whereas the female sexual dysfunction, the lead person was Rilwan and Dr. Saira. So these are the study sites. It was a multi-center study. A multi-center study. You can see the Aga Khan, where Saira, she works. They have Lions. And Gatundu, you can see my village hospital out there. So one of the study which has proceeded, actually it has been submitted for publication, but you're yet to finish the whole process. These prevalence and associated factors of sexual dysfunction among female living diabetes in Kenya. The background for this study is that female sexual dysfunction is prevalent, however, is underappreciated and under-researched. There are few data regarding this. And you can see the background is that it's the factors leading to it, they're both physiological factors and psychological factors. When now you get the sexual dysfunction, it has impact heavily on the quality of life. So our aim was to highlight the prevalence of female sexual dysfunction and related factors among women living with diabetes, and maybe enhance awareness and promote interventions aimed at improving their quality of life. This was our study design. As I said, multi-center prospective study. We picked our data almost 2 years ago. And the study population, we had 421 women were enrolled across the 3 participating centers. The tool we used was the Female Sexual Function Index. It is a 19-item validated questionnaire assessing 6 sexual domains. 1, the desire, arousal, lubrication, orgasm, satisfaction, and pain. And this, we had a review of retrospective data review, and we extracted relevant clinical variables. What are the dependent variables? So using the females, the tool that we used, we assessed the female sexual dysfunction using the Female Sexual Function Index, and the score of less than 26.5 was categorized to have sexual dysfunction. For the independent variables, we picked the socio-demographic data, which included reproductive age at marriage, menopause, FGM history. Then the lifestyle included tobacco use, and we uses the Audit-C questionnaire for the alcohol consumption. Physical health, we checked the blood pressure, and we calculated the BMI. The diabetes-related factors, there was which type of diabetes, which treatment the patient is on, the duration of diabetes, and the diabetes control using the HbA1c. The data was analyzed, and Bonnie was our main statistician for this. And we had description statistic, chi-square, exact binary and logistic regression, odds ratio, and the p-value, and microlinearity. For this result for the female sexual dysfunction, as I say, the total was 421 women who have diabetes. The mean age was 51 years. Majority had type 2 diabetes. Majority were employed, married. Half of them were in postmenopause, and it was a relatively obese population with a mean BMI of 30 kilograms per meter squared. We found that female sexual dysfunction is quite prevalent. Almost 76% of this study population recording some form of sexual dysfunction. And this is a summary of the statistic of the tool that we used. You see across the 6 domains, we have the desire and the arousal. You see the median and the cutoff. And as you see with this statistic, across all the domains were lower than the cutoff. As you can see, from 3, the pain was the least of importance. So for this study population, the commonness, the domain that were highly affected was desire and the arousal. What are the factors which are associated with sexual dysfunction in our population study? I should have started with the other, this was supposed to be the first slide. Age, as you can see, remains significant both for adjusted and the unadjusted p-value. The adjusted odds ratio. As you can see, the p-value for both adjusted, it was less than 0.001, remaining significant. Whereas the urban residents, was found to be significant for both adjusted and adjusted. But the rest of the factors did not reach significant value. In conclusion, this study highlights that female sexual dysfunction is quite prevalent among us female or women living with diabetes in Kenya. There were multiple factors, but was significant. It was age and having an urban residence. What was our recommendation? That we want to enhance female sexual dysfunction awareness, because this is a subject that is ignored in our population. We need to implement regular screening now that we have a validated tool that we can use, and maybe integrate management strategies in diabetes treatment to improve the overall quality of life in patients living with diabetes. That is the first study. I'll move on to the second study, which I was, myself and Dr. Kelly were co-PIs. So this one looked in the male population. So this erectile dysfunction and ejaculation symptoms among men with diabetes in Kenya. The background for our study is that male sexual dysfunction is common but under-recognized, just like the female sexual dysfunction, and is a common complication of diabetes. They are using the DSM-5. There are four domains which they are checked. There are common types of male sexual dysfunction. We have the erectile dysfunction and premature ejaculation. Those are the commonest male sexual dysfunction. However, the others, you have delayed ejaculation and hypoactive sexual desire disorders, which are not commonly studied, and from the data we picked, they were not common. So these two conditions impacts negatively on the quality of life, intimate relationship, psychological well-being, and treatment adherence. We noted that there's limited data in Africa, especially in the sub-Saharan Africa, and most studies normally have focused on the erectile dysfunction. There was scarce data on premature ejaculation, and overall data on male sexual dysfunction was also scarce. What was the aim of our study? We were to assess erectile dysfunction, ejaculatory function, and the associated demographic and clinical factors among us men living with diabetes in Kenya. These are study methods. The study design, cross-sectional, 393 men with diabetes. We had 2 assessments, we had 2 tools. The International Index of Erectile Function, which was assessing erectile function, and the assessment tool for assessing the ejaculation function using the index of premature ejaculation. Those are the inclusion criteria, and we collected demographic, socio-demographic, lifestyle, and clinical parameters. And the data was analyzed using the univariate and multivariate logistic regression. These are study variables. We have the dependent, where using the erectile function, the tool, 5 domains were assessed, and the ejaculation function, we use the index of premature ejaculation. For independent variables, they were just the same as for the female, but this one we also had the HbA1c and the duration of treatment. Data analysis, as you can see, is as discussed in the others. So in the result, the mean age of our study population, these are middle-aged male. A majority had achieved good high education attainment, the high employment rate. There was substantial overweight and obese burden, and nearly half of them, 48%, were living with hypertension. So what are the summary of this statistic for these domains? As you can see, in the total of 393 study population, the mean election function was, medium election functions was 19, and with less than 26, it was classified someone to have erectile dysfunction. And across the board, you can see intercourse satisfaction, orgasmic function, sexual desire, and overall satisfaction, they're all reduced. So what are the proportion of our patients with erectile dysfunction? The population which had sexual dysfunction was 79.4%, whereas only 20% did not have sexual dysfunction. And these rates agrees with other studies in Africa, in the Asia population. What are the factors? Just like the female, we found age and urban residence to have quite significant, whereas university education, as you can see, there's a tendency, a borderline significance of 0.01, but 0.05. However, BMI, hypertension, physical activity were not related to erectile dysfunction. The summary for premature ejaculation domains, as you can see, the ejaculation control, there are 3 domains for premature ejaculation. There's ejaculation control, there's sexual satisfaction, and distress. And this, our study population, the ejaculation control was moderate levels, together with the sexual satisfaction. Our study population experienced relatively low distress related to ejaculation problems. What are the factors? It was found age, urban residence. So the younger you are, the higher risk you had of having premature ejaculation, and also living in the urban center. And this affected across the 3 domains of control and distress and sexual satisfaction. BMI also had, BMI on the other hand, had a negative, that with the higher your BMI was, the more risk that you have the PE plus the obesity. So having a high BMI and overweight was shown to have a significant risk for having premature ejaculation. However, the other factors like physical activity, level of alcohol use, hypertension, employment status, and duration of diabetes did not have a clear association to premature ejaculation. What are the clinical implications for this study? We need to incorporate screening for sexual dysfunction in men type 2 diabetes, to use the validated tools, which they're very visible and they're easy to use, promote the healthy lifestyle, and also adopt a multidisciplinary. I know Dr. James Ecole had presented to us. We would need to work closely with our urologists, the psychologists, and diabetes educators. In conclusion, sexual dysfunction is quite prevalent in male with diabetes in Kenya. ED was common, and ejaculation symptoms the burden was also substantial. Older age and urban residency
was shown to have consistently some significant. And recommendation we may need to do a longitudinal design and also assess why do people who live in urban residency, which you have seen in female sexual dysfunction, erectile dysfunction, and premature ejaculation, urban residency was shown to be a risk factor. This is our acknowledgement. This study was sponsored by the Kenya Diabetes Study Group. This is the first one that they have sponsored, and you're hoping they're going to study more. We had some study assistants who assisted us, and the institution that allowed us to access to the data of their patient. Thank you.
Yes, thank you, Anne. Precisely within 15 minutes, and you are done. Asante sana. Tumpigie makofi mengine. And I'm glad this session, or this presentation, didn't have a section for questions. So that's the beauty about it. However, I will request the colleagues who are taking over from here to allow her to respond to some questions because now we are moving to the actual scientific conference. Primarily speaking, scientific conferences should be about research and improving our data. So President Rose, I think the scientific conference is beginning now. As we move to the research arena. So what I simply want to say following that is to request all of us to stay within the hall because there's a tendency, once we start this research arena, people start moving out. So that's why I'm saying it's the actual scientific conference. So let us all stay in, listen, and at this juncture, I want to welcome my colleagues, Olive and Kelly, to take over and take us through the next session. Thank you so much.
Good afternoon. We can stand for a brief energizer. Let's stand. Even your standing is very sluggish. All right, so left hand, right hand. You guys are facing this way. Okay, so your right hand, put it across. Good, make sure it's about shoulder length to the person next to you. Okay, the other hand, put it across such that you rest it on the thumb that's next to you. No, rest it on the thumbs. Don't overshoot, rest it, excellent. Like how the first line is doing, Syra, instructions. There, good. So the whole point is, when I say one, okay, put your hands back down. When I say one, thumb out, right hand. When I say two, rest this one on the person next to you. Are we following? Then when I say three, you try and capture the thumb that your left hand is resting on. Okay? Then the ones who are captured will come to the front and we'll have a dance challenge. So try not to be, or you can be captured if you think you'll win. There'll be an award for that. All right, so 1, 2, 2. I did, capture is at 3. I haven't said 3. 3. Who has been captured? Please bring the one you have captured. All right, we try it one more time. One more chance to save yourself. 1, 2, 2. Don't panic. 3. All right, we can sit. So we are very proud that this year we received one of the highest number of abstracts we've received in the last few years. So we had a total of 20 abstracts presented for this conference. Excellent material from across the country. Special mention to all the registrars and residents across all our university and collegiate programs, EXACOP being the one that trains physicians amongst the collegiate, our universities, so Moi University, Nairobi University, Aga Khan University. We are very proud of what our trainees are actually doing and putting up their hand to present this at conferences. So tomorrow, over and above this afternoon session, we'll have an excellent morning, 3 hours of more case presentations facilitated by different consultants from the hospital. So the research corner doesn't end today. We encourage you to also attend tomorrow from 10 to 1 to be able to listen to more interesting stuff about what people are actually doing on ground in terms of guideline-directed management and the reality of how to adopt all these guidelines we've heard of since yesterday in actual practice, not just in the private arena or private hospitals, but also in the public hospitals and so on. So we have a total of 5 oral presentations this afternoon. But first, I'd like to introduce our judges. So first, we have Dr. Bundi Karau, consultant physician neurologist. Dr. Bundi, please come up front. So those occupying here, unless you are a judge, I will ask you to maybe move to this. Or judges, where would you like to sit? Middle or up there? Excellent. So judges, you can just go up front to this stage. So Dr. Bundi, welcome. Dr. Bundi is also the managing editor of the Journal of the Kenya Association of Physicians. And as you know, when you present an abstract and it's accepted as, they can see from, I think, this screen. When it's accepted either as a poster or oral presentation, the good thing is we also publish the same in the JOCAP. So for those of you looking to write and do more research, as you know, JOCAP has grown to get a lot of traction in the region. So it's actually a good thing to present and be published. The second judge is none other than Boni Ale. Welcome. You guys have said you'll go on stage. So yes. So Dr. Boni Ale is a pragmatic researcher, clinician, and a very passionate educator. Will also be serving as one of our panelists this afternoon. And finally, we have Dr. Catherine Gathu, consultant family physician and medical educator, currently working at the Aga Khan University Hospital in Nairobi. So that will be our panel of judges. We'll have a total of 5 oral presentations. We'll also have ranking and awards for the best presentation of the afternoon. So we'll start with the first presenter. I hope they are in the room. So the first presentation is entitled Missed Opportunities in Diabetes and Metabolic Syndrome, Prevention Among Postpartum Women, a systematic review. And the principal investigator for this study was Francisca Francisca K. Welcome, Francisca.
Good afternoon, everyone. So it's Francisca Kuliman-Kudia, not Francisca K. I'm a registered clinical nutritionist by profession. I'm a postgraduate student at Kabarak University. I'm at the proposal defense stage. And this systematic review is part of my thesis, which is titled Behavioral and Psychological Determinants of Postpartum Weight Loss among postpartum women living in Lower Kabete sub-county. Hopefully, by the end of my data collection and dissertation, I'll be able to present it in the upcoming conferences. So, on this background, this is a song we have sung from the beginning of this conference. And we see the statistics there, whereby type 2 diabetes, among other metabolic syndrome, is one of the fastest growing global health concerns that greatly affects women of the reproductive age. And approximately 589 million adults globally are living with diabetes, of which these numbers are expected to rise approximately to 830 million by 2050. This is according to the International Diabetes Federation, published last year, 2025. So in Africa alone, we have an estimated 24 million people that is by 2021, who are living with diabetes. And we expect this number to rise to 55 million by 2045, which is not very far. And I think if we do a study today, this number has already gone up, of which I tend to believe that a good percentage is contributed by women of reproductive age. So again, in Kenya, we see approximately 813,000 adults aged 20 to 79 are living with diabetes. And this corresponds to a prevalence rate of 3.1% in 2024. Again, I tend to believe that if we do a research today, this number would have gone up. So these numbers, again, we see are projected to rise to 1.8 million in 2050. Gestational diabetes is one of the risk factors for type 2 diabetes among postpartum women, and its prevalence rate is at 4%. That was according to IDF in 2025. From this systematic review, I've come to realize that millions of women leave the maternity or leave our health facilities carrying the strongest predictor of type 2 diabetes, and most of them don't know, and we tend to lose them immediately they leave our facilities. And the ones who are going to contribute to this 70% of women who are going to transition to diabetes mellitus in 5 years to come if no interventions are implemented. So again, postpartum women are at a high risk of type 2 diabetes, and especially those who've had a history of GDM, a high BMI, not only those who have GDM, but you might have had a high BMI before pregnancy and into pregnancy again, a high gestational weight gain and weight retention, and a high fasting glucose. That is according to World Healthcare Organization in 2021. So limited postpartum follow-up on the health and nutrition status, as well as social cultural factors also impose risk to type 2 diabetes among this vulnerable group. This is according to a study done in Kenya by Cherono, Wheeler, and Remigius. Those are not from Kenya. So why is postpartum period a unique period or a window of opportunity to prevent type 2 diabetes? This is because we tend to see these mothers oftenly in our facilities, but not for the sake of their health, but for the sake of the health of their children. If you compare to the number of patients we receive from outpatients, maybe the walk-ins, and the number of patients we receive in our MCH, you'll realize that MCH has a very high number of women coming in, but mostly we focus on the children and we forget about these postpartum women. So the objective of the study was to systematically review evidence on missed opportunities in prevention of diabetes and metabolic syndrome among postpartum women in high, low, and middle income countries. Methodology of this review, according to the PRISMA guidelines, a thorough research literature search was performed in 4 electronic databases, that is PubMed, ResearchGate, Google Scholar, and Cochrane Library for missed opportunities in diabetes and metabolic syndrome prevention among postpartum women from January 2015 to April 2025. So the keywords used for this search were missed opportunities, or postpartum and diabetes, or metabolic syndrome and prevention, or gestational diabetes, or postpartum women, or lactating women adapted per database. Inclusion and exclusion criteria, again, according to the PRISMA guidelines, studies were eligible for inclusion if they were qualitative studies. We have the RCTs, the observational studies, cross-sectional studies, or mixed method studies. And this included postpartum women of up to 5 years after delivery, including those who've had a history of GDM, excessive gestational weight gain or even retention, or other metabolic risk factors. The studies must have been focused on missed opportunities, the barriers or prevention strategies, and must have been published in English between January 2015 to April 2026 without any geographic restrictions. Data extraction, so the following information was included, or we had to look at it: the author, year, country, study design, sample size, key findings, and regarding the missed opportunities or prevention, and reported barriers to care. So all these findings, I believe I shared the full article, were synthesized narratively according to one thematic area, which is the main focus of this review: the missed opportunities in prevention of diabetes. So the findings: search identified 58 articles, 6 of them were duplicates, 5 additional records were identified from the reference list, and initial screening of the abstract and titles left 28 articles for full assessment for eligibility. In summary, 20 systematic reviews met the inclusion criteria. Now, the main findings on these missed opportunities were untimely screening, whereby we see the research revealed that one-off glucose test at 4 to 12 weeks is insufficient. This because the American Diabetes Association recommends screening up to 3 years postpartum. I don't know if this is what we practice in our facilities. I highly doubt. Low screening rates, we tend to see as low as 5% to a maximum of 60% of women attended the postpartum glucose testing. Loss of continuity of care, fragmented care. This is the elephant in the room, whereby we saw unclear provider responsibility. The healthcare providers don't know whose responsibility it is to follow up on these postpartum women. Poor coordination and lack of integration between the specialist and the primary care. Lack of a health system designed to follow up on postpartum care. Underutilized breastfeeding benefits. We have campaign for breastfeeding, majorly because to promote the health of the child, but we have forgotten about the metabolic effects on this postpartum mother. So it is also good to emphasize on that. Again, suboptimal adherence to available clinical guidelines, despite the fact that our guidelines have gaps in terms of management of the postpartum women, we still see suboptimal adherence from the healthcare providers. And then the last one, self-reported barriers by postpartum mothers, where the mother tells you she didn't know, she has no time to come to the clinic, or maybe she has other child responsibility, and etc. So this is a summary of what the American Diabetes Association recommends us to do, or rather the strategies to improve postpartum engagement, whereby we have seen low postpartum screening rates. A mother reports after delivery, no one reminds me about the glucose test, I thought I was fine. So the American Diabetes Association reminds us to discuss this test during admission so that we don't miss, and also place an outpatient order for the OGTT at hospital discharge when available. Combine the postpartum exam with the well baby visits when possible so that we don't miss the mothers, and also counsel during pregnancy about the importance of continuous postpartum glucose testing. We also see mental and emotional health, where we also bring in the psychologist, as well as discontinuity of care after delivery, where we quickly transition these mothers from specialized care into primary care. Life course prevention. No one told me my risks last for decades after pregnancy. We need to keep on educating these mothers. So in summary, this review shows an alarming failure of the healthcare system to use this window of opportunity provided in the postpartum to prevent these mothers with a history of GDM from transitioning to type 2 diabetes. We all know the lifestyle interventions have been proven to have a great impact on the metabolic health of the mothers. So this failure is contributed by fragmented healthcare system, whereby the mother is quickly transitioned, like I have said. Additionally, these preventive strategies have not been integrated into postnatal healthcare, which results to an increase in low screening rates among this vulnerable population. In conclusion, from prevention, we know we need to screen, we need to intervene, we need to implement these lifestyle interventions and also promote breastfeeding. Now, in terms of precision, we need to have tailored, individualized interventions based on the risk profiles of these mothers, use of digital health tools for reminders, integrate care models, linking the specialists into and the dietitians and the community health workers. And also we need to integrate the prevention of this type 2 diabetes and other non-communicable diseases into maternal policies, as well as resource allocation for continuity of care. You'll find that maybe probably there's no capacity in a facility, there's no nutritionist in that facility, or maybe a diabetes educator to be able to give these interventions. And that is the end of my presentation. And those are some of my references. Thank you.
Thank you, Dr. So our next presenter is going to be Imran J. Please come forward. Are you around, Imran? Yes. As you come forward, we cannot overemphasize what we are being told since the beginning of the day, whereby we may assume that diabetes arising in pregnancy drops when the baby is delivered. So Imran is going to be speaking to us about diabetes distress and its correlation with glycemic control among type 2 diabetes patients. And this study was done at Moi Teaching and Referral Hospital, Eldoret. Karibu.
Thank you so much. So I'm going to introduce my study. This is a study that was conducted in 2024 from January to June. And the title is Diabetes Distress and its Correlation with Glycemic Control among Patients with Type 2 Diabetes. It was done at MTRH. So what's diabetes distress? I know we have had a lot of talks on diabetes, so I'm going to skip that part in the background. So diabetes distress is an emotional burden and worries and frustrations that come with living with the burden of diabetes. It's very clinically distinct from depression, although they interchange and they interact to worsen the glycemic control among patients with diabetes. In our study, we used a DDS-17. This is a tool that is validated across many African settings to actually look at all the 4 domains of the diabetes distress, namely emotional burden, which is worry, fear, and guilt about living with diabetes and the complications that come with it. Regimen distress, this focuses on the diet, medication monitoring, and medication adherence. Physician distress, this looks at the interpersonal relationship between the patient and the healthcare provider in terms of access and communication and even patient satisfaction. And interpersonal distress, which stems from interpersonal relationships, family, support from friends and colleagues. Diabetes care is a daily work. Like we have been told, we have moved from glycemic control to actually integrating every other aspect of the patient. We are looking at the patient holistically and not just the numbers in terms of HbA1c. It's a daily work and not just a single clinic event whereby the patient comes, you take RBS, you check their HbA1c, and then you book them for the next visit. So these daily decisions, they are daily decisions in terms of diet, medication, activity, what to do by the patient that they have to make. Now this actually leads to self-management load that make the patient increase, or sustained effort is required before you can actually get that HbA1c improvement. And then you look at the glycemic outcome after having all these input from the patient in terms of the daily decisions, in terms of this effort that they are putting. Now, if this self-management is the treatment, then definitely distress is a treatment limiting factor. And for many patients, the metabolic burden and the emotional burden are actually both inseparable. So what's the local problem? The psychosocial barriers are rarely measured. Growing up from undergraduate, from postgraduate, it was not part of the routine care that you will actually see when a diabetic patient or a patient with diabetes actually comes to the clinic. The routine is that the patient comes, the vitals are taken, the RBS is taken, and then the patient actually goes direct to the doctor, and where the doctor, they discuss the numbers. So the burden is known, but then there is this clinical blind spot whereby our routine care just focuses on that medication adjustment. Today you are using this, your HbA1c is more than 10, we are going to put you on insulin, or you have cardiovascular complications, we are going to put you on SGLT2, but we actually fail to look at that psychosocial aspect of that patient. And then the evidence gap is that we have very limited local data across Western Kenya and even Kenya at large. And there's only one study that was done in Nairobi that looked at diabetes-related distress, but it actually used a different tool. So if this DD, diabetes distress, is actually not recognized, it may continue to undermine self-care. And that's the first point of actually treating diabetes. The self-care is the first point whereby the patient gets their management of diabetes. So our study went out and asked, is this diabetes distress that we are hearing about, is it prevalent in our setup? It is prevalent in international stages, whereby the prevalence actually ranges between 25 and 35. So we went out and first looked at the prevalence, and then is it actually independently associated with glycemic control? Yes, we know these patients have diabetes distress, but is it actually independently associated with glycemic control? So that was our research question, the prevalence of diabetes distress and how it correlates with glycemic control among people living with type 2 DM at MTRH. Our objective 1 was to find the prevalence of diabetes distress. Objective 2 was to check the level of glycemic control so that we can sort of put a comparison between those patients with poor glycemic control and those patients with good glycemic control and how they differ in terms of their diabetes distress number. And then the objective 3, using multivariable analysis and correlation analysis and comparison of means, we actually checked for associations between diabetes distress and the glycemic control. So the methodology, we did a cross-sectional study design at MTRH. Our exposure, we were looking at the diabetes distress using the diabetes distress 17 tool. It's a 6-item. It has 4 domain and it's on a 6 Likert scale from 1 to 6. And then the outcome was to check for the serum HbA1c and then correlate the two. So what were our results? These were the population. The inclusion criteria was the diagnosis of type 2 DM, follow-up at MTRH for at least 6 months, and able to provide informed consent. Excluded non-psychiatric disorder or substance abuse because it could act as a confounder to the diabetes distress. Any patient who was actually on antidepressants, which is actually a confounding, and pregnancy with diabetes, because pregnancy, as we have been told, comes with own stress that is related specifically to the pregnancy. So what did we see? So our population was actually clinically and socially high risk. Why clinically? Number 1, 75% of them were actually either overweight or obese. And this is very interesting because most of the studies that looked at our patients before, the number of, or the percentage was actually ranging between 45 to 55. And then 64.1% were actually on insulin, any insulin use, whether the patient was just on insulin or the patient on orals plus insulin. And then the duration of diabetes, 36.4% of our patients had diabetes for more than 10 years. 52.8 had comorbid hypertension, and 63% of our patients were actually uninsured. So to our objective 1, whereby we looked at prevalence of diabetes distress, so we actually found that 15.8% of our patients living with diabetes actually had diabetes distress, and the mean DDS score, the diabetes distress score, was 1.53. with the clinically significant diabetes distress starting from 2 and above. And the range that were observed were between 1 and 4. And then in terms of domain-specific distress, the emotional domain was the one that dominated, with more than half of our patients actually were complaining of diabetes distress. I remember participant number 1 was actually when we started, when we were interviewing her, she actually went into tears because of the emotional distress that was coming with living with diabetes. And then it comes to regimen distress because of either the medication burden, the pill burden, or even the access and the financial implications that come with the treatment of diabetes. And then interpersonal relationship, because of most African setup, we find that we have some good interpersonal or good social and cultural coping mechanisms. And interestingly is that physician distress got the least. I don't know whether this was some desirable bias from the patient. So this was a caveat, maybe because of when we were interviewing the patient, they wanted to actually make us feel that we are doing a good job in treating them. So in terms of level of glycemic control, actually our mean HbA1c across all our participants was 9.34, and 57.4% of our participants had actually either poor or very poor. And we categorized our poor from HbA1c of more than 8. HbA1c of less than 7, that was optimal control. 7 to 8, that was good. And 8 to 10, that was poor control. And anything above 10 was very poor control. And then this means that more than 57%, 57% of our patients had a HbA1c of more than 8, and only 11% had optimal control. I think I'd done this. I'm going back. Okay, in terms of the linkage between diabetes distress and the worsening glycemic control. So here, as you look at HbA1c categories, whereby we had categorized into optimal, good, poor, and very poor, you'll actually find that the diabetes distress was on an upward slope going. From optimum, we only saw that 2.3% of patients who had optimal control were actually having diabetes distress. And then very poor, in terms of the HbA1c categories, 19.8, almost 20% actually reported diabetes distress. In terms of the mean HbA1c difference, 10% reported distress. I mean, the mean HbA1c was 10, and the mean HbA1c in those who did not have diabetes distress was 9.21. The difference, if you look, is 0.79, and it was clinically significant in terms of both the confidence interval. This 7.9 might seem a very, very small number, but if you look back at literature, HbA1c of just above 0.5 to 1 is actually linked to worse outcomes with diabetes. And then in terms of adjusted predictors of poor control, those with diabetes distress had odds of having poor control 2.3 times of having poor control compared to their counterpart, and those who are on insulin had 3.39 odds of having poor control. So what does this mean then? We have found the numbers. We saw that diabetes distress is actually significantly correlated with poor control. So what's next? So these results actually suggest that distress is not just it's not just a psychosocial burden, but is actually a risk marker when you look at the difference in terms of mean of their HbA1c. And this can actually be a bidirectional cycle whereby someone either starts with high HbA1c, they have more worry, more guilt because they are told if you are not controlling your diabetes, you are going to lose your leg. What was just discussed, if you don't control diabetes, you are going to have sexual dysfunction. So this brings worries, this brings guilt. And then it tips the patient to diabetes distress, more commonly the emotional distress, and then the patient ends up having reduced self-care. All these now end up having a burden on the patient in terms of the treatment burden, and then we have like sort of this vicious cycle. So What's our conclusion and our key takeaway? So 15.8% of our participants had clinically significant diabetes distress. That means 1 in every 6. The latest diabetes number, the prevalence of diabetes in Kenya, it was around 813 as of 2025. If you take 15.8, that means around 128,000 are actually living with diabetes distress. And then 57.4 had that poor or very poor glycemic control, and the adjusted odds ratio of those who were distressed on likelihood of having poor control were 2.3 times. So what is the next step now after this? What should we integrate in our clinical practice? So number 1, screen. Like the way we were told in the morning, you screen. You screen for patients whether they have this diabetes distress, especially when they are clinically high risk. Number 2, you stratify the patient. Is this patient actually having a clinically significant diabetes distress that would warrant intervention? And then number 3, you start introducing support in terms of family support, interpersonal support, and strengthen their medication and adherence support. And then number 4, this is where we lack, and this is something that we need to consider, is that we need to refer our diabetes patients to either psychologist or psychiatrist for further management and interventions. We are not asking you to become mental health units, but we are just asking you, when you detect diabetes distress, please refer appropriately, because studies have shown that when interventions have been put across the diabetes distress, there's actually improvement in terms of HbA1c and glycemic control. So diabetes should not stop us from exploring other things, and as clinicians, let's explore diabetes distress. Thank you. I would also like to acknowledge my co-authors and my supervisors, Dr. Jemima Kamano from Moi University MTRH, Department of Internal Medicine, and Professor Benson Gakinya from Department of Mental Health. Thank you.
Thank you so much, Imran. Excellent work, don't you agree? So we are at a point where we can't say we don't have our own data. That's why we're encouraging more and more people to do similar studies. Please publish, so that even when we write up, we can cite local material, and that improves our visibility as researchers in Kenya. Next. So for the upcoming presenters, please remember, you only have a 10-minute slot so that we can go through the remaining presentations. So up next, we will have Angela Wangeshi, and Angela will take us through macros AI. So using an AI-powered nutrition tracking and coaching application for personalized dietary management. So when we talk about precision, this is what we're talking about in terms of leveraging on AI to be able to improve our practice. Welcome, Angela.
Hello, everyone. My name is Angela Wangeshi. An IT and AI specialist, and also the founder of Afrivance AI, which is a company that develops
grams of carbs, especially in relation. There's limited continuous access to nutritional guidance. These patients, if lucky, will only see the nutritionist once a month. What happens the other 29 days? And then most of the apps that we have are actually westernized. And most of these apps are also built for someone else's plate. There's no local food coverage. And now we have integrated an insulin to carb ratio, which will also help our clinicians or even patients to be able to calculate that. We've used a culturally familiar language, meaning it has a bit of Kiswahili and English in it, and it's real time. A patient can go, keep their data, and bring it to clinic after 30 days.
That's where Macros AI comes in. When we were developing it, we developed it in three main folds. Image-based meal logging, where we use AI food vision, where it identifies the food that you're consuming. Then it gives you a breakdown of the calories, the proteins, and the fats that in that meal. We also have integrated an AI nutrition coach, which reviews your daily intake and also recommends tomorrow's strategy in a culturally familiar language, like she said, Swahili, English. And also we've integrated a diabetes management module, which is focused for carb-focused coaching. The problem we are trying to solve is poor dietary adherence, impedes weight management, muscle gain and control of diabetes, hypertension and obesity. The existing apps rely on Western food databases relevant to Kenyan patients, no Ugali, Githeri, or Sukuma Wiki. Clinicians lack a scalable tool to recommend for real-time patient nutrition self-monitoring. Our approach, as I said, was to build an AI-powered image-based nutrition tracking, built specifically for the African dietary context. 24/7 nutrition coach that analyzes every meal you log in and tells you how you're doing against your goals, whether your goal is gaining muscle, losing weight, and recommends exactly what to eat in next time, in real time. And it also has a personalized AI insights that trends your nutrition over 70 to 90 days so that your clinicians always know how you're progressing. It's developed in close collaboration with specialist clinicians in diabetes and obesity management. It's designed to complement, not replace clinical guidance. It's a tool that clinicians can confidently recommend to their patients. How it works, you go to Google App Store and download it, Macros AI Nutrition Coach by Afrivance AI. Then you set the profile.
So this is how we set the profile, patient profile, together with the clinician and the nutritionist. So we have the patient's data, the patient's goal. So you'll be able to say, does this patient have obesity or does this patient have diabetes? What is their target weight? How much protein do you need to put them on? And then you'll photograph the meal.
And once you photograph the meal, as I said, it will give you a breakdown of the calories, the fats, and the carbohydrates in that meal. And the nutrition coach works 24/7. It's contextually aware of the meals that you've logged in during that day and recommends what can you change to make it better to get your targeted goals. And also the 70 to 90-day insights, where it tracks your protein intake over the 90 days and also your carb consumption.
Okay, so this is interesting because, for example, we'd put you're a patient who doesn't know what to eat, and you can ask him, hi, what do I eat for lunch to meet my protein requirement? And they'll say, habari wangeshi, for lunch, I recommend this meal. And then it will give you a lot. So let's go to...
And I really want to congratulate all of you and thank you for wonderful presentations. Thank you.
Thank you. I'm Boni Ali, and I would like to first of all thank the organizers for inviting me. And I think this is now the third time being the judge for this abstract presentation. So I would like to thank very much the organizers for inviting me each time. I also had the pleasure to always work with Kdsg. Over the years, I've seen a great progress in the way people actually think about research. And for me as a researcher in the core, I really appreciate to see that people are more and more enthusiastic about research, which is very good. And I'm very happy to see that. I would like to also congratulate people who are presented today. Do a presentation in front of an audience it's not an easy task. And I see she's shaking her head, and I really want to congratulate her for her boldness. The other thing is that I think in general, what I will say is that I keep repeating this, you can't do research without mentorship. So you need to find good researchers who can guide you through the process and show you the way. you cannot become a great researcher without sitting under someone and learn. And for me, I think over the years, what I've noticed is that people have great idea, but how to now package it into a good research project, that's a problem. And sometimes you may do something which you think it's very good, but actually it's not a good research project. But for the research that has been presented, all of them has been very great ideas, and this is fantastic. I would like to say that for the presentation, my advice, try to do not use too much AI tools. For all the presentation, because I'm an AI professional, I know that all of them has been done with AI. I do not say that you shouldn't, but as a human, you have to always supervise what the AI is doing. So when I see your presentation, there are a lot of things that the AI has done for you, but you do not modify it so that you can see the human touch. And sometimes when you see people who are reading your presentation, mostly they are over 40 and they can't see very well. So if your police for the writing it's small, already we can't see it. And you have to pay attention to the colors that you are using so that you don't use so many colors. If someone has issues with colors, it can be also an issue. And you have to also to supervise and see, is the AI actually bringing out the message the way I want to bring it out? I encourage people to use AI, but you supervise what you are using. Otherwise, it's come out as robotic, I can see. Apart from that, I think I will just conclude by saying that you have done a great work, and some people among you actually have mastered the topic. They know it so well. It was very fluent, and I encourage you to continue doing research and try to get it close to people. I'm personally available. I like mentoring people, and I will be pleased to work with anyone who is available and wants to work with me. But I have experience of being a tough guy, so sometimes it's difficult to work with me. But I'm always pleased to work with everyone. Thank you.
Thank you so much. A round of applause for all the presenters. A bigger round of applause to our judges as I welcome you up front to take a photo with the authors. So I think it's been wonderful, and since we have the president of Kdsg here, I think it's a challenge that now that people are innovating and inventing, probably other than engaging the Ministry of Health, there's a State Department of Science, Innovation and Technology. I think that's a partner that we should look at engaging in the near future. So Rosie, I'll invite you to also come up front. Being the study group, I think it's only befitting that you come up front and take a photo with, as well as Saira, who's our head of research subcommittee. Please, and of course, Dr. Florence Kelly, who's been extremely instrumental in terms of the abstract review process. Oh, and myself. One, I think the microphone is malfunctioning, but Rosie, if you can just stay and let us know about the plans for the evening. Otherwise, thank you so much for keeping the hall full until this stage. We truly do appreciate. After all, we are the Kenya Diabetes Study Group. So research is really a core element of what we do as a society. Welcome, Rosie.
Thank you, Olive, and thank you for that wonderful session. You've kept us very entertained, but it was amazing. And as for Matiko, challenge accepted. So I've already asked the judges if they're willing to come next year, and you shall see a change in the program. So I'm throwing down the gauntlet, and I'm hoping that those of you who are here will take it back to all the hospitals, whether private, public, that remember we had mentioned that one, we have a small kitty when it comes to research grants. So those of you who have studies, please send it to our head of research, and she has a committee that will look at that. That is one. Number two, we are always open. You can see we are more than happy to host you so that we can see what kind of research that is going on in the field of diabetes and endocrinology. So I throw it back to you, the attendees, that we've taken note of the feedback that you'd want more scientific content, and that's what we are going to do. So we'd encourage you to come and present in our conference. Now, all work and no play makes you very dull, right? So to reward you for being amazing, you have sat through all this. Remember, the program does not end today. You have to come tomorrow. So manage your expectations and your fun this evening. We'd like to actually clear the hall because we're going to have the gala dinner. Remember, it's a touch of green on the outside, not the inside. Tafadhali. And so